is in the, that is again lumen. Now you can see it's actually retrograde, but it's in planes. But I want is the antegrade wire and the microcatheter in the true lumen, retrograde wire in the false lumen. I tried 9 wires. I used more than 10 gray radiation already. So the next choice is leave it alone, new devices, new wires. I tried this wire crossed. And this wire is actually the wire I just wanted to mention. This is called Gladius EX. This is actually having a stainless wire with a tip load of 3 grams, hydrophilic coating of 500 millimeters, a new option for CTO, high lubricity, controllability inside the lesion, hafeesh intermediate polymer guide wire. And after this, I took the balloon down, nothing is crossing. I took a balloon 1.5 not crossed. With the help of one big nano balloon, it is crossed, balloon dilated. I did an IVUS to understand I'm in the true lumen or not. I was totally in the lumen. I put 3 stents, 3.5 48, 2.75 38, 2.5 23. But then I understood I was actually not getting the PDA. I should get the PDA back. So for getting the PDA, what I did is actually I tried passing the wire from the retrograde, but I was failed. What I did is I tried to cross the stent wire. This wire is a Gayatri wire. You can see the Gayatri wire. With the help of the microcatheter sitting in the PDA, I tried to cross. You can see the wire crossing. This wire went directly into the PDA. I crossed the wire into the PDA. Once I crossed the wire, I again did a balloon dilatation and then did IVUS. This is actually the main, the tap stenting, 3 into 12 millimeter balloon, 4 into 12 millimeter. This is the final angiogram. I got the result after this. The last is actually, this is a case number 8. You can see there is a microchannel coming up. We will be feeling it is very good. So there's an antegrade CTO attempted, antegrade RC attempted somewhere else. I'll be seeing there are 3 channels. This is a channel, is an angulator channel, 1. Second channel is this channel. The third channel is the third one. So out of the 3 channels, I tried the first channel. I thought I'll be crossing, but I took a microcatheter. I'll tell you what microcatheter this is. This angle is difficult, Philipsi wire. This Corsair Pro X. Basically, this actually having a distal access, lesion crossability, excellent profile, and it should not rotate too much more than 10 times, otherwise it will cause. Finally, this is not crossed. This is not crossed. This is not crossed. Antegrade is no chance, but I crossed with this wire. Again in the first channel, second branch. This wire, you can see the angle. This angle is almost taking a different angle, completely blind. 1 second, finished. They wanted to finish. Gayatri crossed, 3 stents, final. Conclusion, new wire is a Gladius EX, new microcatheter is Corsair Pro XS, new child catheter is telescope, new CTO balloons are Ikazushi Zero and Nick Nano. New devices makes our life more easier and create more success. Thank you. I think the
Thank
question
you,
should come
for those that excellent talk and giving us information about these new devices. Any questions from the panel?
What is the usual indication for these patients actually? How do they present in your experience? Is it ACS or?
No, these patients actually usually come with an angina. They actually come with an STEMI. Most of the time what we see is actually the patient come with the angiogram done from STEMI. They put a stent in the other vessel and the LV is totally normal, but other vessels are diseased, untouched by people. So it is actually either you should refer for the 2 lesions to the CABG or 2 lesions you have to tackle. So most of the time whenever I get a patient, I just do it.
What is the ACS somebody presents? They do a stent from the culprit vessel. Then they leave a CTO unattended. This is collateralized the way you have shown in most of the cases. What is the usual indication? Stable angina, effort angina?
No, this all, most of the cases are stable angina patient is very, very less. Most of the patients present with STEMI, the other 2 vessels are to be tackled.
Now, Pradhaban, I just have a question. What about this 1 millimeter Artemis? I've been using this quite a lot. One Artemis. There is a balloon.
I personally feel that those balloons are not so good.
No, but it really works even when you have 1.2 Tazuno or things like that.
Tasuna is actually, I still feel that is a very good balloon.
That's what, in cases where it has not caused, this has helped.
This is actually a personal interest, and I tried these balloons in many places, but I personally feel that I could not. I tried to cross Ikasushi 0Y, one side cross, it was easily, and I used this balloon for septal channel dilatation. I went to a workshop in Bhavanagar. They had only one microcatheter and there is no balloons, and I was in trouble situation. I used the microcatheter and used this Ikasushi balloon and channel dilator. 4 CTOs, retrograde CTOs I did for that patients.
And this balloon comes in 4 millimeter diameter also?
It is, Ikasushi is available in 4 also, but that is mainly used by Japanese for the kissing balloon inflation.
0, I thought it doesn't.
Ikasushi 0 is only 1. 1 means they are telling it is almost like a wire.
But you said 1 to 4.
1 millimeter, 1 into 6 is millimeter. That, for that size they call it as Ikasushi 0. Otherwise it is called Ikasushi balloon.
Okay.
Thank you, Dr. Pradhaban. I think we have had a wonderful discussion, and I would like to thank all the chairs and panelists. For want of time, I think we have to go to the Dr. Joe. I think we can please invite the next one. Yeah, next session.
So we will go to the next session, session number 3, tackling the unexpected. I request the chairperson, Dr. Sajeev Kurutugulam. Dr. Sajeev is here, and Dr. Shiva Prasad. And I welcome the chairpersons as also the panelists, Dr. John and Dr. Sujay Renga, to take the session. And it's a long session. It's from 5:30 to 7 o'clock. Over to you, Dr. Sajeev.
Good evening. Now we move on to the next session, tackling the unexpected. We have a series of excellent talks lined up and elegant speakers. We move on to the first talk, LMCA bifurcation stenting by Dr. N. Salim. Dr. Shiva Prasad is here. Can you show?
Can you show the online people, chairperson?
Yeah, and the panelists. Yeah, they're all here. Okay.
My patient is a 59-year-old male who had inferior wall MI, and that time he underwent PTCA to LCX. That was in August 2019. He had a borderline LED ostial stenosis that time, which was conserved, and he developed progressive angina since April, and subsequently he developed an ACS enstomy in May 2021. He is a hypertensive dyslipidemic with a creatinine of 1.6. This was the angio taken, which showed ostial LED 99% stenosis and ostial ramus 90% stenosis with a patent stent in the LCX. This is the angio shoots. And the plan was CABG versus multivessel PTCA, and it was discussed with the patient parties as well as the patient, and they opted for the PTCA. And the strategy was to do the LMCA LED stenting with a POBA to ostial ramus and LCX using them. And right femoral artery approach was taken, and 7 French catheter was used. The lesion was closed with a run-through wire, and LCA ramus was wired. And LM LED was pre-dilated using 2.512 balloon, and the ramus was also pre-dilated, and LED was dilated with 3.25 and into 12 balloon subsequently. And this is the post-dilated shoots. And then LM to LED was stented using 3.5 into 48 everolimus eluting stent, and then port was done using 4 into 6 Q-force balloon at 18 atmosphere of pressure. And subsequently, the entire LED stent was post-dilated. And this is the OCT run after the post-dilatation, which showed a well-deployed distal and mid part of the stent, but the ostial LM part was malapposed. You can see the malapposed LMCA stent, which was then subsequently post-dilated with 4.5 into 6 millimeter balloon. Then kissing was done using 3.5 into 13 NC balloon at LM to LAD and 2.5 into 15 NC balloon at placed at LCX and 2 into 12 NC balloon at left mid ramus. And then drug-eluting balloon was used. Drug-eluting balloon was used to dilate the ramus as well as the left circumflex artery. And this is the final result. You can see a fairly good result. And the final OCT run was taken, which showed a well-deployed LAD stent, including the left main. And you can see the side branch strut well open, and there is no strut across the side branch. So to conclude, the LMCA trifurcation stenting requires meticulous planning and care, and when it involves two side branches, care should be taken to choose the strategy. Many times it's a good idea to keep it simple with provisional stenting techniques, and drug-eluting balloon has a promising role in treating the ostium of side branch when the lesion length is small. Thank you.
If you want to consider a trifurcation stenting, what strategy you would have thought about in this case? Not audible. Okay. Can you unmute? You're not audible.
Hello.
Yeah, you're audible now, yes. Yeah, you can go ahead. Can you unmute?
Yeah. Can you hear?
Yeah, if suppose you want to go for a trifurcation stenting in this case, what is the strategy you like to?
Yeah, I wanted to make it simple this thing because the artery size was totally missed. The LED size, size, all very different. So I wanted to make full strategy.
And have you used a drug-eluting balloon in both ramus and circ, or only into one?
The same balloon was to the both for benefit. Circumflex was also dilated using the drug-eluting.
Yeah, over to you. Any questions? Dr. Shiva Prasad is here. Joe, anything you add on?
Dr. Anil, this is regarded as a dominant circumflex. Why choose to put a drug-eluting balloon into the circumflex? I would think that I would directly go and stent the circumflex and most likely put a deb into the ram. Why you choose not to put a stent into the circumflex and use a drug-eluting balloon for both ramus as well as the circumflex?
Actually, the priority is to dilate with the drug-eluting balloon. Because the ramus ostium was deceased, circumflex ostium was deceased, and the circumflex, only the strut was open. And since the drug-eluting was used for the ramus, it was used for the circumflex for whatever the.
Yeah, there is some problem with the audio. I think that is a very wonderful case. Thank you, Dr. Salim. Any more questions?
So we'll go to the next session.
Yeah, I think we'll go to Joe. You can.
So this is regarding a distal LMCA bifurcation, LED aneurysmal lesion, oscillator guided PCI by Dr. Ramakrishna CD.
Good evening, respected chairpersons, moderators, and my dear friends. I am presenting the case of distal LMCA bifurcation in LED aneurysmal lesions where I did OCT guided PCR. Patient was 57 years old female. She was diabetic and hypertensive. She had effort angina for 6 months duration, presented with ACS and in the other hospital, and echo was normal LV function, and there was no regional was motion abnormalities. CG done outside showed left main and double vessel disease, and they advised CABG. Ideally, patient required CABG, but she was not at all willing for CABG, hence planned for OCT guided PCR. Chuck shoot with guide catheter, there is significant distal LM lesion and where plaque body in the ostial circumflex. LED having diffuse lesion from ostial to distal LED, there is aneurysmal segment in the mid LED at the origin of plaque. OCT pullback from left circumflex to assess the ostial circumflex. There is significant lipid containing plaque as well as fibrous plaque in the ostial LED with significant luminal compromise, and LMCA was normal looking. OCT pullback from LED, again there is diffuse lesion from distal to ostial LED, plaque, fibrous plaque and calcium containing lesions, multiple calcium containing lesions, and just before the origin of diagonal there was big aneurysmal segment, mission around 4.5 mm. And also ostial LAD is again multiple calcium containing lesion and significant luminal compounds. Measurements from OCT, mid-LED aneurysma measured from lumen to lumen around 4.5 mm. LED ostium luminal area 2.39, multiple calcium lesions, and LMCA, mid-LMCA was normal and measuring around 4 mm. Radialization 2.5 to 15 balloon, multiple radialization to prepare the bed. 3 into 23 drug-eluting stent taken and distal LED was stented. 3.5 into 28 drug-eluting stent was taken and from overlapping stent that the LED and proximally in the distal LM. Stent was inflated to allow atmospheric pressure. Post-dilated with 3.5 into 10, multiple post-dilatation, and the chuck shoot after the post-dilatation. So there is significant pinching of ostial circumflex and the plaque shift from the LED and some flow compromise, and the circumflex rewired. It was open and 4 into 28 drug-eluting stent was taken and it was positioned in the mid-LMCA and circumflex, inflated to 2 lakh atmospheric pressure. In this case, I followed flow technique because LCX was big size vessel, around 4 mm vessel, and angle was more than 70 degrees. I thought flow was ideal for this case. Chuck shoot after the stenting, port with 4 mm balloon, SKBD with both 3.5 mm balloon, report with again 4 mm balloon, and with a chuck shoot after the report. OCT pullback from LED to assess the stent apposition the aneurysmal segment. There was significant malapposition in the aneurysmal segment and stent was well approached in LMCA. Post-dilated with the 4 into 9 non-compliant balloon, high pressure dilatation up to 20 atmosphere pressure, and final pullback, OCT pullback from LED to assess the stent expansion and stent apposition the aneurysmal segment. Very well approached, and LMCA stent was very well approached. The final angiogram, and there is T3 flow, and to follow up, patient withstand the procedure very well. She was hemorrhagically stable throughout the procedure. It was done in 2019, 2 years follow-up. It's stable, asymptomatic, and check angiogram was not done. Started on DHPT, ticagrelor and aspirin, still she is continuing. Take home message in this case is a complex lesion because there is distal LM bifurcation lesion, diffuse ciliary lesion containing aneurysmal segment and big size circumflex, 4 mm circumflex, ostial plaque body in the circumflex. So imaging is must for these type of cases to assess the center expansion, especially in that aneurysmal segment as well as left main. So initial proof is occipital that showed 10 malappropriation in the aneurysmal segment and post-dilated again with the high pressure balloon and higher balloon, and so it was properly approached and expanded. So even though the decay curve 3 and 5 trial has shown that there is decay curve is better than color, this case that we select technique based on the size of the vessel as well as the angle of the vessel. In this case, L6 is big size vessel, the angle is more than 70 degrees, so I thought color is ideal for this case. Then optimization with imaging is crucial for better short-term and long-term outcomes. Thank you for your patient listening.
That is a wonderful case. The diameter at the size at the vessel at the aneurysmal segment was about 4.2. Do you have to really postulate in that situation? Really have to, even if, is it okay to have a little bit of malapposition that area to expand?
It was measuring around 4.5. So, but in the occipital back there showed significant malapposition. So we can leave it alone like that. So definitely we have to do something. That's why again post-dilate with higher balloon with higher pressure and repeat pullback showed there was good apposition. That was accepted.
What was the balloon used in the aneurysmal segment?
For
What was the size of the balloon?
Yeah, for 4 into 9. And it was inflated to almost 20 atmosphere pressure.
John, you have any questions? Over to you.
Yeah, that was a good case, Ramesh. Usually when we do a QLOT, we stent the more angulated segment first. So we had planned for a two stent strategy at the outset. I think it would have been easier to get into the stent the circ first, because sometimes you might have difficulty in negotiating, especially if the stent is long into the circ. So this was a planned 2 stent strategy or a provisional strategy.
Regarding the strategy, because in this case circumflex was almost equal, little more than LAD, and angle was not very short. If it is angle is less than 70 or less than 50, definitely you have to go for crush. And the angle is not that much short, and then L6 is bigger size vessel. If it is an equal size vessel, we have to go for culotte, and this is almost more than LAD. So I thought culotte was ideal for this case.
One question, was an angio done at the end of 2 years or it was a clinical follow-up?
Angio.
Circumflex ostium which has not restenosed. Any comments?
Because I don't know, patient doesn't have any symptoms. If she may be having some restenosis, we don't know. But if you do the angio, but as there is no symptoms, because usually there is difficult to convince this patient for check angio, because if there are no symptoms, they won't agree for that.
That was a nice case, Dr. Amarchan. Joe, any questions? Joyce here? I think we'll move on to the next one, DK crush with imaging, Dr. Matthew Paul.
Good evening, Chairperson, senior colleagues, and my friends. Without much introduction, let me just straight away go to the case. 60-year-old male presented with acute anterior wall MI, presented to the ER. He had mild LV dysfunction. He was straight away taken up for primary angioplasty. His angiogram revealed mid-LAD 100% lesion, which was the culprit. He had a left main disease and a circumflex disease as well. So anyway, as planned, only the culprit lesion was dealt at the time of primary angioplasty. 315 drug-eluting stent was placed in the mid-LAD, and he was planned for an elective PCI to the left main bifurcation on another day. This was how the angiogram looked on the day of the staged procedure. He had patent stent in the mid-LAD, which was done 2 days ago. And the left main distal part had a tapering lesion extending to the LAD and a very tight lesion in the circumflex ostium. So looking at this, we plan to go ahead with a DK crush as the bifurcation strategy. So an OCT was performed prior to the procedure after placing the wires in LAD and LCX. There was a stent seen in the mid LAD, and we are going to get an opportunity after 2 days, we thought. So anyway, this is how it looked from the LAD. Had some proximal disease, and a run was taken from the circumflex as well, which showed a tight disease of the ostial part. So this is how it was performed. A stent was placed in the proximal LAD with the distal part overlapping over the other stent. There was around 4 millimeter part of the stent protruding to the left main. 312 NC balloon was placed from the left main to the circumflex to crush the protruded part. LAD stent was deployed, and after removing the balloon, left main to LCX balloon was inflated to crush the protruded LAD stent. After this, carefully another wire was used to cross the crushed part of the LAD stent. Of course, I would like to confess here that though I had OCT at that time, I didn't use it to find the appropriate strut through which I should cross the wire, because crossing the wire itself was a tedious job, so I didn't go for, I was not very over ambitious to get any particular strut. After crossing through the mid part of the LAD strut, I used a 1.2510 semi-compliant balloon to open up the strut, after which I used a 312 NC balloon in the LAD and 2.512 NC balloon in the circumflex for the first simultaneous kissing dilatation. After this, the wire, balloon, everything was removed from the LAD. A stent 3.528 drug-eluting stent was placed from left main to LCX and was deployed. This is how it looked post-deployment. And a 4.58 non-compliant balloon was used to do the port at the left main. After this, a wire was used to cross the LAD again through the struts. It was, the struts were, a 1.2510 semi-compliant balloon was used to open the strut initially. And after that, 3.512 NC balloon was used to dilate or to expand the ostial part of the circumflex, which was very tight, and I felt that it is not properly expanded. So after that, for the second simultaneous kissing dilatation, 2 312 NC balloons were used in both LAD and LCX, and the simultaneous kissing dilatation was done. After that, a port to the left main was done with 4.58 non-compliant balloon. And this is how the OCT looked after the post-dilatations and port. The LED stents were looking properly apposed, and the carina was also looking reasonably good, and there was no much crowding seen at the carina. Both the ostium of LED and LCX were looking alright. The stents were properly apposed, and a fly-through video was also done, which showed the ostium of LED and LCX, and as it shows, no much carinal crowding, and the stents looked reasonably apposed. And the final angiogram revealed well-expanded LED LCX stents and the left main part, and patient remained stable throughout the procedure. Thank you.
A beautiful case, Dr. Matthew. John, any comments? Your comments, please, first. Yeah, of course.
Matthews, I wanted to ask you a question. Now, in a Two reasons, sir. One, the size of circumflex was slightly bigger than the LAD, more comparable to the left main size. Another thing, LAD was an infarcted area, and I thought I should be giving more preference to the circumflex, and that's why I chose LAD as a side branch here.
Yeah, but generally in a circumflex that is non-dominant and an RCA dominant, the circumflex supplies only about 10 to 12% of the myocardial mass. So whether the angiogram looks, the circumflex looks big or looks small, the LAD in an intravascular ultrasound EL size will always be much larger than a circumflex.
Here in the case, after 2 days only I took for the stage procedure. So when he came with the anterior wall MI, the middle AD was the culprit, and even after 2 days the flow was not that great. So I just felt that the myocardium is not that great. So I didn't want to give much burdens to LAD at that time.
So Matthew, one question to you. See, if I've seen the angio correctly, the LAD ostium was not all that tight compared to the circumflex. Circumflex definitely was the. So in fact, in the new concept which has been in the ABC main is that you can even do a provisional stenting, going from the left main into the circ, and then look at what happens to the LAD and take a call subsequently. So what is the opinion? I mean, how would many people in the audience think about that? In fact, Goran is a big advocate of this.
No, but I think we go back to the question about myocardial mass and how much the LAD subtends. I don't think you can do a provisional from the LM to the circumflex and just open the strut to the LAD. You can do a provisional from the left main to LAD and then leave the circumflex. But a reverse provisional with an LAD so big, and though you say that it's probably non-viable and things like that, I think would be.
No, that's exactly the point. In fact, this is exactly the point I wanted to convey. Nowadays, they advocate doing it from the left main into the circ when there is a large LAD there, and they say the long-term follow-up is as good. I don't know.
Does that make much of a difference? I think what you have done is reasonably all right, because it is already infarcted, and the amount of viable myocardium, if we take into LAD territory, back circ is actually a very big vessel, very big territory also.
So I have done LAD as provisional in a case where there was no much ischemia issues. I have left it like that. In this case, I didn't want to just open up strut for the LAD, because LAD is also equally important, though there is an area of infarction.
John, any comments from your side?
Yeah, I think that was a good demonstration of a DK crush. But I think this would be a good case for a TA protrusion also, because of the wide angle between the LAD and the circ.
Any more comments from the audience? Any comments? Okay, thank you, Matthew. That was a wonderful case and a very good demonstration of this situation. We move on to the next case, presentation by Dr. Pratap, LMCA instant restenosis. Over to you, Pratap.
It is an interesting case of LMISR. A 31-year-old female had an acute coronary syndrome and stable angina. She had undergone a CABG in 2012. She had undergone a LIMA to LAD and CABG done only for LMCA disease of 95%. Her PMD is positive now, and echo shows an anterior wall is hyperkinetic with ejection fraction of 50%. He was admitted for an angiogram and a PCI. She was diagnosed to have a Takayasu arteritis without any other disease in any other vessels and anemia. She has no diabetes, hypertension or family history. Her angiogram shows a completely occluded LMCA. You can see there is no catheter is cannulating, but we can see some flow by the injection. This is actually the right coronary injection showing excellent collaterals from the PDA. So the plan of action here is via the retrograde CTO, just open the LAD. So I took a JR 3.5 catheter with a Caravel and a filler FC. That is my usual practice. But to my surprise, the Caravel as well as the filler FC crossed and reached up to the opposite vessel. So the Caravel reached the left main and it is crossed. Once it is crossed, I tried with a cyan black wire. Cyan black is tried, but it is not reaching up. No catheter is cannulating. So I tried snaring, but I failed. Once I failed, then I tried with a UB3 wire, tried retrograde. Again, I tried snaring, failed. But antigrade injection, by this time, my microcatheter had gone 3-4 times outside, so produced a faint flow. So I could see a faint filling of the left system by antigrade flow. So I thought I'll keep the catheter in a different angle, like an epicranial. This is a JL catheter. I tried with another projection to try an antigrade entry of the wire. So what I saw that my wire, you can see the wire is now entering, but I could the wire inside. Once the wire entered, that entered into the Y branch. I put one more wire and dilated the vessel, because the wire did not go to the LAD, and this dilated with the wire, and it is 2.5 in the Maverick balloon. Once it is balloon dilated, I took a XTR wire and just that is crossed into the LAD. Once it is crossed, I took a IVS run and to see what is happening. There is a plaque in the ostial LAD which was 9.5 millimeters size. You can see the distal reference is very good vessel, and the vessel lumen is also very good. I took a 3.5 into 26 stent, that is a resolute onyx stent, which is actually, then after the stent, I did an IVS again. I was showing an ostial LAD of 8.28 and LMCA of 10.26, and distal edge is actually perfect. This patient actually, I did a Maverick balloon of 4 and very well dilated and finished the case. But the story does not stop here. She had an LMCA, and this actually the patient came with an ISR. Once the ISR came, the patient actually, we did angiogram again, severe angina. So this actually, I tried to cannulate. You can see the cannulation is a very important step. So I tried to cannulate the wire. You can see that I tried to cannulate the wire. The wire is cannulated with keeping the wire. I don't want to take the wire abluminal. I wanted to take luminal entry of the wire. You can see the wash the wire actually. This is entered luminal wire entry. Once the wire entered, I took a Philrepsy wire, dilated with a Maverick balloon. Subsequently, I did a pre-OCT. You can see the OCT showing a significant plaque burden, which is actually the tight disease in the ostium, lot of neointimal hyperplasia. I took a Flextom 3 into 10 millimeter balloon, and there is a bifurcation pre-run done. You can see the ostial opening is also very good there. And we did a Maverick balloon 2.75 12 and a 4 into 20 magic touch. And this is the final OCT run showing an excellent opening with an area of 9.94, and opening is very well. And this is the final run with this vessel. Thank you very much.
Do we have a follow-up? Excellent case, Pratap.
No, it's only 4 months second procedure. I'm just waiting that she comes back again. The second time, I did the first is actually CABG done at the age of 24. After 7 years, she got a LMCA occlusion. And then we did an angioplasty with IVS guided. We thought everything is perfect. Now she came back exactly after 3 months. So I don't want to put another stent. I decided to do a drug-eluting balloon. But luckily, in the initial procedure 3 months, now it is 5 months over, and she is doing extremely well so far. I don't know whether she will come back again, what I should do again.
The etiology is arteritis.
She is on Visalon, ESR is normal, and she is actually no activation and all. And otherwise, no other problems.
The lesion yielded initially easily, or was it a very tough lesion?
Initial CTO, the first one, LMC CTO. There actually I did a balloon dilatation, then I did a cutting balloon that time also. This time again I redid a cutting balloon. You can see the neointimal hyperplasia is very, almost like occupied total neointimal hyperplasia. We could not understand what is the anatomy. If you analyze the initial case, we did not do an OCT to understand the media, intima, adventitia very well. We don't know what Takayasu tells that. But I did not show some of the steps where when I was planning to take the wire out and exteriorization, I was really in trouble. So first channel I went, I took the wire out, I could not. So I thought maybe because of the different channel I go. I went another channel and went up. So once you wire gone up, maybe in the aorta itself there will be a lot of diseases. So you cannot even cannulate and take the wire up. It was a real tough time. not crossing the CTO, to take the wire up, snaring. When I showed this case, actually, Dr. ABM was telling, Pradap, you show again the steps. But since it's a 4 minutes, I cut all the shots.
What was the first time that you put?
I put 4 into
Onyx.
I think, no, it is Resolute or it is Onyx, I think.
I had a similar case of arteritis where I did a drug-eluting balloon for a racinosis, and he came back with racinosis.
No, it is natural. Actually, what Dr. George Joseph telling that for the carotid disease, you may do the ISR cutting balloon 4-5 times. What he told me, after 5-6 times, the coming down will come down and patient will do very well after some time. I think I am also expecting, and I actually made the patient to understand that she will again come back.
The disease activity is another predisposing factor for racinosis.
That is what Saji, actually I am very much, her ESR is 5-4 only, and always she is doing very well and no other disease.
Okay.
Do a PET scan. Sometimes the ESR can be misleading.
Okay.
PET scan is
Pradap.
Yeah, John, any question?
John.
When you have an instant restenosis in the left main, what is your experience with the use of rock ablation in such patients? Suppose, have any experience with that?
No, John, without a severely fibrotic disease, actually severe fibrotic disease, you can do a rotablation. People actually use laser in some of the cases. Actually, I have done a LM ISR. I just went back to my cases, and LM ISR I have done nearly 15 cases, and 10 cases are doing very well with the drug-eluting balloon. That is my experience. I just wanted to publish the data so that we don't have that much data in the world literature, because people are thinking it is nothing can be done. But drug-eluting with the sirolimus balloon, that is actually the magic touch. There is a really good result. I'm just thinking about how to publicize these things.
Sujay,
Sujay is not there, I think.
Sujay is not there, okay.
Okay, thank you.
Any more comments?
Thank you.
Can you? We move on to the next case. That is a wonderful case, Dr. Pratap. If somebody shows his angio and without showing the name of the hospital, who has done it, it is definitely, we can identify the person who has done it. The lion can be identified by the footprints. We move to the next case, simultaneous kissing stent by Dr. Rajesh Parlitharan.
Good evening, everybody. Thank you for the opportunity. Our patient is an 86-year-old gentleman, an active social worker from Wayanad. He is diabetic. He presented to us with ACS, non-STMI, severe LV dysfunction. He was in pulmonary edema. He had recurrent hospitalizations for pulmonary edema in the past. He had other comorbidities, and he was one of those kind of patients who was stuck because of recurrent hospitalizations. This was an angiogram done 9 months prior to the present admission from elsewhere. It shows a heavily calcified LAD and circumflex. RCA is totally occluded and is collateralized from the left side. He was offered bypass surgery versus medical management at that time, and he continued to be on medical treatment. He was taken up for a coronary angiogram. An elective IAPP was placed, and the angiogram revealed severely calcific LAD and circumflex. OCT was not considered in him to assess the coronary calcium, considering that he is sick and that his creatinine levels are higher. IVUS was not available, and IABP was the best mechanical circulatory support that we could give him. Whether we should go ahead with IVL or a rotablation in this setting, if we look at one of the proposed algorithms to deal with the coronary calcium, this part of the chart is irrelevant to us because we could cross the lesion with a balloon and pre-dilate. We decided against intravascular imaging, and then the decision between an IVL versus rotablation is based on whether the calcium is deep or superficial. And if you get a suboptimal balloon expansion after a rotablation, to proceed with an IVL. So we decided to go ahead straight with IVL upfront. There were 6 dilatations of IVL with a 2.5 to 12 millimeter balloon, because the distal most lesion we thought to be 2.5 millimeters. The balloon dilatations were good and giving a reasonable expansion. This was followed up with a This was followed up with a 3 into 10 mm angioscopic balloon dilatation at 16 atmospheres. The distal LAD was stented with a 2.5 into 32 millimeter stent, and simultaneous kissing stents were placed in the LAD and circumflex right from the ostium of the left main. The distal LAD stent was post-dilated to 2.575 millimeter balloon. And the proximal part of the stents were post-dilated to 3.5 millimeter balloon, and the final kissing balloon dilatation was done with 3.5 into 15 millimeter NC balloon in LAD as well as circumflex. So this is the final result after the procedure. He is presently back to his social work, and the post-procedure report, approximately 6 months post-procedure, shows mild LV dysfunction. Thank you.
This is a case of SKS. Why did you choose to do an SKS in this situation? Any particular reason?
So we wanted to finish the procedure as soon as possible. So the emphasis here was on the time, and the hemodynamics was borderline.
Yeah, that is what,
systolic blood pressure.
Yes. That is one situation. As a bailout strategy, SKS is justified to be done because it carries a significant amount of restenosis in the circumflex ostium. John, any comments?
Yeah, as mentioned, I think SKS is considered only in such situations when you have a hemodynamically unstable patient with renal failure and you want to finish off the procedure as soon as possible. So this patient was relatively sick. That's why he was put on IABP and he just wanted to finish off the procedure first. And
also the LM was short. LM was short. So that was another thing favorable in this situation.
And we covered the ostium with both the stents, so that the only issue with the SKS is you should not land up with a proximal dissection in the left main.
Here you covered up to the ostium of the LM.
Yes,
Yeah.
sir.
Dr. Rajesh, wonderful case. Imaging always helps him to differentiate IVL, whether you should use IVL or rotablation. This case also you have not done imaging because of the hemodynamic unstable state, or?
Yes, we didn't do imaging because of the borderline creatinine as well as hemodynamics.
But before going for IVL imaging, usually whether you should go for imaging before going for IVL?
Always, that's preferred, but in this special scenario, probably it would be better not to do that.
No, I think Rajesh, actually, I don't think this patient is such a crashed patient and hemodynamically so unstable not to do a normal type of a stenting. I don't think it is actually, you could do a patient with a DK crush or a mini crush technique in this case. There is no doubt about it. You should prepare the circumflex first and then LMCA to LAD and stent to that. I don't think that was the reason for you. You may be thinking that you would have thought that this is a very bad patient, you should finish it fast. But I personally feel that, and number two, you told imaging was not done because of the high creatinine. IVUS can be done without, there is no...
We didn't have IVUS, sir. We didn't.
Any more questions? Thank you. We will move on to the next case. Thank you very much. We will move on to the next case is a case of shifting hematoma. Dr. Sebu. Sorry, I think we missed a case. LMCA distal bifurcation by Dr. Raghuram. Sorry.
Good evening, one and all. I thank the organizers of ICK for having given me this opportunity to present in front of you. In this session, I'll be presenting left main distal bifurcation PCI, where we did a tap stenting in acute coronary syndrome, and we also have a 2-year follow-up in this case. So this is a 65-year-old male who came in with an acute anterior wall MI presentation. Angiogram taken after a quick angiogram, and you can see that the distal left main has a 99% lesion with T0 to 1 flow in the LAD as well as in the circumflex system. We quickly wired the LAD. and dilated the left main distal and the LAD ostium, followed by wiring of the circumflex and dilation of the LCX ostium. In this case, we planned to go in with systematic TAP stenting. So we have a 3.5 into 26 drug-eluting stent from the left main into the LAD. And then you can see this fair result at the LAD ostium. So then the next process to rewire into the circumflex. Here it's important to rewire to the distal strut. I'll come to why it is important a little later. Then you can see we perform the pot of the left main, and then we introduced a 2.75 into 12 drug-eluting stent and at the left main ostium with minimal protrusion into the 1 to 2 millimeter into the left main. And then we brought back both the balloons. There was a balloon in the LAD and brought back the LCX 10 balloon and did a kissing balloon inflation. You can see this was a fair result with the L6 ostium well open. So the patient had an uneventful course for 2 years, then presented complaints of chest pain. Since it was left main bifurcation case, to come up for a check angiogram. Check angiogram reveals the fully patent left main stent with even the left circumflex ostium fully open. So this is a very gratifying result for all of us. So TAP stenting, originally conceived as a bailout strategy after positional stenting, has been a go-to procedure for many interventionalists, even now when they approach a bifurcation PCI as an elective case, a two-vessel case. An anticipated pitfall of this technique is that a single-layer neocarina created by the side branch stent strut protruding inside the main vessel. Conversely, in the rest of the bifurcation area, TAP allows full stent coverage. A recent bench study comparing TAP with crush and QLO showed that the stent strut malposition in the proximal vessel and the maximal wall milepost strut distance are significantly reduced by TAP technique. So it's also important to ensure rewiring is always through the distal strut. This is because once we rewire through the proximal strut and we dilate, what happens is that the proximal edge now is bereft of strut coverage. So to ensure that you don't miss covering the full ostia, you may have to bring back the stent into the left main to ensure a proper coverage. So if you dilate through the distal strut, then the proximal edge is now still covered by strut and by the stent edge, and so you can do the TAP stenting in a desired fashion. So TAP stenting is an ideal technique for the left main distal bifurcation, especially in emergency situation. An ideal bifurcation angle makes it all the more suitable. The technique has a less number of steps with a very good initial outcome, and as our case proves, long-term outcome is also favorable.
Thank you, Dr. Raghuram. That is a good case. And was it something like a trifurcation? I thought it was in a very early OM. Was anything done to the ostium of the...
There was not a significant ramus or OM. So we just concentrated on the circumflex.
Baulen sir, are you available if you can give your comments?
No, I think it is a nice case of, demonstrating how provisional stenting could be done. And as Ajay asked, that circumflex early origin probably doesn't require any intervention. My only question is that, what is the strategy of using drug-coated balloon in bifurcation? Was it a prior intended use of drug-coated balloon? And second question is that if in bifurcation drug-coated balloon is planned, will you utilize it before stenting the main branch or after stenting the main branch? Because you have to deliver the drug to the ostium of the circumflex. If you have a stented one and then you go and deploy the drug-coated balloon, how sure you are of the elution of the drug to the ostium?
Excellent question, sir. But I think this is probably open for the panelists as well to join in.
Okay, Dr. Madhu, can you give your insights? Are you available?
Yes, Adi. It's a nice question, Colin, sir.
He has passed the ball to you.
Raghunath, just pass it on. Yes, if the ostium comes as stenosis, it's going to be difficult. And drug-eluting balloon is probably after the stent. And especially if in a tap, you have to be extremely careful that you don't, miss the carina in between. So if that gets distorted, then the problem of restenosis again happening is quite high.
Drug-eluting balloon can be used, as Bhavlen sir was mentioning, can be used after stenting when there is an ISR, maybe.
Maybe, yeah. Otherwise, if you have an upfront intention is there, it is preferable to use first, because after the inflation, the balloon is deflated and came out. If you again use it for kissing balloon inflation, part of the drug will be taken out by the balloon. So I think one has to be keeping these points in mind when you use the duck cotton balloon in bifurcation. Thank you.
Any more comments? We'll move on to the next case. Thank you, Dr. Raghuram. That is a wonderful case. A case of shifting hematoma, Dr. Cebu Matthew.
Good afternoon. I would like to thank ICCK and Dr. Jayagopal for giving me this opportunity to talk to you on a case of shifting hematoma in LMCA bifurcation. Our case is a 67-year-old female with previous angioplasty to RCA. She had effort angina and we planned angioplasty to LAD. These injections, we can see that the LAD is diseased in the proximal and middle LAD and the size is not very big. We did a pre-dilatation of the LAD with 2x15 semi-compliant balloon and we got reasonable flow. A stent was placed in the mid to distal LAD, 2.25 into 24 everolimus depth, and we tried to pull out the balloon of the stent, and we can see that the catheter is guiding catheter is diving in. Then we placed a stent in the proximal LAD overlapping with the distal stent, 2.5 into 19 everolimus depth. And by that time, a hematoma had developed in the roof of LMCA, and by the next injection, the LAD has occluded. So we deployed the proximal stent and then proceeded to LMCA to LAD stenting. LMCA to LAD stenting was done with 3 into 24 everolimus depth, and a port was done in the LMCA with 4 into 6 millimeter non-compliant balloon. After that, we did a check injection and then removed the LCX wire. But with the proper injection after remove the LCX wire, we can find that the LCX is occluded with shifting of hematoma. We rewired the LCX and then we did a tap technique to the LCX. The LCX ostium was dilated with a 2.5 into 15 NC balloon, and a tap was done with a 2.5 into 19 everolimus depth, and a final kissing was done with the stent balloon in the LCX and 2 into 15 non-compliant balloon in the LAD. And this is the final result. We can see that the LAD and LCX ostia are patent and flowing well. The take-home messages are, we have to be careful when pulling out the balloon after stenting, especially long lesions. Adequate preparation of the lesion before stenting is needed, and especially use non-compliant balloon of intended stent size. And has gone in. A tight section. A shift of hematoma to LCX is interesting in this case. The hematoma shifted from LMCA to LAD to LCX. A check injection was given in our case before removing the wire, but it was not properly evaluated. Hence, LCX wire was prematurely removed. The lesson learned is assess the flow properly before removing the side branch wire. Option other than stenting in the hematoma in LCX is the use of cutting balloon to release the hematoma. TAP was done in this case. TAP is an easy option for provisional second stent in bifurcation lesions. It leaves a neocarina. A final port is to be avoided if the balloon is likely to distort neocarina, and we did not do a final port. Thank you for your kind attention.
Thank you, Dr. Sibu. That was actually a beautiful demonstration of how hematoma happens, or if you are not careful about the guide catheter when the balloon is pulled out after the stent is deployed. And it is nice to see sometimes the hematoma can shift into the aortic root sometimes. It not always into the circumflex. Luckily, you are able to cross into it. And in that situation, you prefer to use a long stent in the circumflex because it can get skewed again and go forwards if you use a small stent. Baulen sir, any comments, sir? Sir, you're not audible. You're not audible, sir.
No, this happened when you have pulling back the balloon. This is not only the hematoma. One other problem is that when you in tap itself, after tapping the side branch stent and deploying it, if you pull back the balloon, it can drag the stent back into the left main. And that is another complication if you don't take care of this pulling back of the balloon after deployment.
Dr. Sibu sir, interesting case. Would you say it is hematoma without doing imaging? Because hematoma usually we'll see in imaging. Just with the angiography, can you say hematoma?
We did not do image for the student. And what else can it be? Because there was a hematoma from LMCA to LED, and the distal and middle LED was already stented. The hematoma cannot fuse down, so it has to be shifted to the LCX. And there was not significant disease in the LCS ostium.
It possibly could have been a dissection of the left main. The dissection would have also gone into the circumflex, because I could see some contrast stain there, even when you're deploying the proximal stent in the LED.
Yes, there was a contrast staining in the LMCA root, followed by a portion of the LED. So it was a hematoma which spread to the LED.
Now, if you just say a dissection in the left main, that could explain everything, isn't it, bro?
I did not get you. That's it.
Yeah, Madhu, you're not audible. We did not get it. What is your comment?
Or if you just say it's a dissection, as Jagopal is saying, I mean, there's obviously dissection in the left main. So that can explain everything, rather than saying a hematoma, which is probably unusual and without imaging, you can't say.
Possible. John, any comments?
I think imaging is the best way to differentiate this, because you have the typical hyperechoic images with echolucid areas because of the trapped RBCs, which is a hematoma on iris. So I think it could, otherwise it could be a coronary spasm or a dissection, so it's difficult to differentiate. So I think to be 100% sure whether it's a hematoma, I think IVUS is required.
I think we come to the end of the session. Thank you, Dr. Sibu. We now go into...
Thank you.
Animal? Pardon? Now we are going into an interesting part of it, the case-based learning session. And this have initial case presentation by Dr. Jayagopal. Then Dr. Madhu will explain how he would do this. And Dr. Jayagopal will finally reveal how he has actually done it. And then we have a final concluding talk by Baulen sir. So over to Dr. Jayagopal.
Good evening, everyone. Dear friends and senior colleagues. I thought of having a case-based discussion here on a fairly common problem that we face in the cath lab, where I think most of us may not be, in an emergency, may not be getting the desired devices to really assess a patient. So the case scenario is a 76-year-old gentleman who has been under my care for a long time, more than 2 decades, diabetic for 25 years, on insulin, wheelchair, hypertensive, hypothyroid. And then he had actually a complete heart block and dual chamber pacemaker done in 1997 and a generator change in 2009 and then doing fairly all right. He was admitted with history of burning pain, chest and breathlessness of 4 days duration and was actually referred from another center. And on admission, he had features of heart failure clinically. ECG showed a pacing rhythm, evolved anterior wall myocardial infarction. Echo showed a regional wall motion abnormality with LAD with an EF of 35%, slightly elevated PA pressure in distress, and then he was on diuretics, decongestive measures, and then taken for a CAG next day. You could see that the blood parameters are fairly okay, the renal function was normal, elevated troponin 3.78, and then taken up for an elective angio next day. He was stable at that point of time. So that was a left shoot. This is a fairly common thing which you would see in today's practice. You could see the tight left vein, the ostial LAD, ostial circumflex, and very diffusely diseased LAD. As you could see, there was even an lesion in the mid portion of the LAD. Now that's another view. So the tiger catheter actually went in. So I probably couldn't figure out the entire thing, but then with a fairly decent angio which revealed the anatomy quite well. This is again another view where all the shots have been taken. The left caudal, very tight circumflex, but then this guy had an anterior wall myocardial infarction. The right was fairly okay, and you could see in both views, and the pacemaker, everything was functioning quite well, and that's what we thought at this point of time the significant diabetes, renal function fairly well preserved. He had a pacemaker, so the option was given to him, both cabbage and PCI, high risk PCI. So he was in two minds, shifted to the room that night. Next day afternoon, 3 p.m., severe chest pain. At that point of time, with significant ST depression, and the family members at that point were very, very keen that they would go with the high risk PCI. And on that day, the creatinine was 1.3. So this was taken as sort of a emergency procedure, and I leave it at this point as to how mother would tackle this particular patient. Thank you.
Over to Dr. Madhu.
It's recording. Good evening. So here we're going to talk about how would I treat this case. In summary, you got a 76-year-old male who is a long-standing diabetic, well controlled with HbA1c of 7.2, RFD is normal, who presented with ACFs leading to LVF. ECG showed a pace rhythm with bundle branch block, and echo showed RWMF LAD territory with ejection fraction of 40 and RVSP of 60. So, the left main, distal 90, LAD ostial 90, mid 70, circ ostial 90, OM1 proximal 90, and RC is normal. So you got a double bifurcation, distal left main and left circ to OM1. The syntax score is 31%. You don't have enough data for syntax 2 or syntax 2020. So this is what we have with the syntax 1 score. CABG obviously is doing better, and the syntax score is 31, but it's still in the intermediate range, 22 to 32. So what would I do? Long-standing diabetes, LV dysfunction, left main with multivessel disease, syntax 31. The first option obviously is bypass, but of course angioplasty can be done. So the points to consider are, one, this calcification of the proximal circumflex. You got a relatively long lesion in obtuse marginal. You got significant lesions in LAD here, mid and probably mid to distal. And if you look here, the circumflex lesion is pretty long. It's not restricted to the ostium. And you got an upward takeoff of the OM1 from circumflex. So it'd be difficult to wire, and there's likelihood of closure if it's not protected. So this, in fact, fits in for a complex bifurcation. This is the definition criteria for complex bifurcation. You got the left main, Medina 111, distal left main 90, involving more than 10% of the ostium of the circumflex. So this is a complex bifurcation. And we know that for complex bifurcation, there's a 3-year outcome of the DK crush 5. DK crush is better than a provisional setting. So it has to be a 2-stent strategy from the beginning, and possibly a DK crush. So what would be the strategy? It is a complex left main bifurcation. Result should be equivalent or better than surgery, which is the first option. So we should aim to make the intervention in the best possible manner. So imaging is a must, either IVUS or OCT. FFR is preferable for the severity of the mid-LAD lesion, and the aim should be to have the minimum number of stents which are optimally deployed, and DK crush would be the technique used. So how would we do? It should be a femoral approach. It has to be a 7 French guide, preferably an ABU. And the guide wires, you have to have 2 or 3 guide wires, of which one should be a hydrofilic. In my cath lab, I would probably be using a run-through NS hypercoat and a cyan black as a hydrophilic wire. So the wiring, you have to put wire into the OM1, OM2, and into the LAD. OM1 supplies a large amount of myocardium, so this has to be protected. And the calcification of the proximal circumflex that needs assessment. So if it's significant, you would need to do something for the circumflex lesion. So decay crush, you have to pre-dilate into the LAD and OM1 to get hemodynamic stability, followed by OCT into OM1 and LAD. You have to assess the calcium with the MLD max algorithm of OCT. If there is significant calcium for the proximal circ, that has to be debulked either with a Wolverine or a cutting balloon or an intravascular lithotripsy. I would be hesitant to do a rotablator with so many branches rising close to each other and so many wires put in. And OCT has to be done post-plaque modification to assess for the efficacy before we implant the stent. And stent has to be from left main to OM1, not OM2. OM1 is a large branch and you have to protect the OM1. So stent would be from left main to OM1 because the lesion in OM is long and cannot be salvaged without a stent. After stent to OM, the distal circ has to be assessed. If there is pinching of the distal circ, that would be rewired, stents are dilated into the distal circ and probably a kissing balloon. If the result is good after that, it would be left. If not, we probably would be putting another stent with a deprivation strategy with a tap to the circumflex. But that probably would not be needed because you can see that the lesion is restricted only to the small segment and probably the beginning of the distal circ. So hopefully we would be able to get away with one stent from left main to OM1 and open up the struts into the distal circ. Crush has to be followed by a pot, and pot has to be done with a balloon which is sized to the left main. Only then would the stent be crushed fully, else the wire would go between the 2 layers of the stent, distorting the whole anatomy. And the distal marker of the pot balloon should be at the carina. Rewiring should be through the proximal or the mid stent. We can see here that if you go distally or try to go for the distal stent, you would be left with a stent-free area in the carina, which would predispose to restenosis. The first kiss, followed by a second crush, this time with a stent from left main to LAD, followed by a repot, a kissing second kiss and a repot. In the kissing balloon technique, you have to have both non-compliant balloons and high pressures alternatively so that each ostia are well open. Here I would probably go to more than 28 atmospheres in each the ostia, followed by a final kissing inflation at normal pressures of 12 to 14. And a repot, the balloon has to be kept a bit more proximal so that the carina is not touched. This is even more pertinent if you're doing a tap where you would have metal in the carina and that should not be distorted with a pot balloon. And so this would be the final result. The final result would be assessed by the OCT and it should have an optimal stent deployment with no medial dissection, should be well opposed in an expansion, ideally more than 90 or at least more than 80%. If the left main LAD circ OMs are okay, then the lesion in the mid LAD needs to be addressed, preferably with the FFR or MLA on OCT. If it's significant, probably less than 2, then you probably would have to put another stent covering those 2 lesions as well. And a final run of OCT and the case would hopefully be finished well. So in summary, there's always more than one way of doing a procedure. The aim should be to get the best results long term for the patient and making it as simple as possible without cutting corners. Imaging is mandatory to ensure that the lesion preparation is adequate and the end results optimum. I'm sure Dr. Jayagopal would have certainly done a great job. Thank you.
Thank you, Dr. Madhu. So we'll now listen to Dr. Jayagopal as to what he has done.
Thank you. Thank you, Dr. Madhu, for a very elegant talk and your concept of how you would do it. Actually, I think the contemporary discussion on decay crush and the contemporary era, I think many people would have done this. But I'll just share as to the procedure what I performed. Now, right femoral, as you rightly pointed out, 7 French guide is a distal LMCA. You have a Medina at 111, distal LMCA 90%, ostial LCX. This is actually progress. When I took a guide shot, you'll see subsequently, middle AD was significant. It was not 70%, it was more than that. Upfront, I think all of us mostly would agree that this is a two-front strategy. So that is what the guide shot was. And in fact, when my presentation was there, I said, I had taken a tiger that had gone a little deep in. So there was a little suggestion of an ostial. In fact, there was a pressure damping as soon as I got the guide in. And you could see the lesions progressed. The circumflex particularly has progressed from the previous day. And so that was a worrying thing. The infarct-related artery was the left anterior descending. So anyway, wiring was no major issue. And my workhorse wire is a Renato. I don't know how many of you would use that, but that's a fantastic wire. With no time the wires were in. And then being an anterior wall MI, I didn't want to really take a chance. And today, I think even in any bifurcation, a pre-dilatation of any branch is optional. And so the LAD was dilated, got a good flow into the LAD. After that, I opened up the circumflex because the circumflex was very tight, and that was probably giving more angina. So this was opened up, circumflex, and the ostium opened up well. I was thinking that I would need a cutting balloon or something there, but then with a 2.5 NC, it opened up quite well. And then my plan, so from the view here, from the LA caudal, it's evident that the ostium is also significantly involved. So subsequently what I did was I actually, initial plan was initially thought of a decay crush, but here I modified it. I thought since the ostium was involved, I might need a stent which will go from the ostium to the main vessel, and in such an angulated vessel, I thought it would be easier to take a stent into the LAD from the ostium, and that would be an easier job. So what I had in mind here was a culotte stenting. I took the stent from the left main into the circumflex, 3 into 18 millimeter resolute onyx, and opened up. It opened pretty well. Used a 3.5 millimeter balloon, even dilated the proximal portion of the stent very well, opened very well, and then did a part of the left main, and subsequently crossing the left anterior, the LAD was not a problem at all. The wire was recrossed, and then it was easy to get initially needed a 1.2 wire to cross into the LAD, subsequently a 1.5, and then a 2 tracked in, and then subsequently it was opened with a 2.5. Once that was done, the mid-LAD portion of the lesion was assessed further, and that appeared very tight at this point of time. So again, I did not want to leave it then. The distal flow had to be perfect. Opened up the mid-LAD with a balloon, and then that stenting was okay. We used a long stent, a resolute onyx stent, right from the proximal to the distal portion, had a good landing zone, and that was covered and opened up very well. And it was post-dilated, as you could see from the next film, and the distal flow was fairly all right. After that, the part of the left LMCA was done. In the iliocranial, it's very clear at this point of time that there was a very tight ostial lesion, and so the challenge and the time taken was actually profile the LM ostium. So the LM ostium was covered, and to get the appropriate stent across, it was overlapped and got a 3.3 into 18 millimeter stent again. It's covered the 18 or 22, I don't remember, covered it very well. And then again, subsequently after that, a part was done. It was recrossed, and just like that, after that it was as a kissing balloon, and then it went on. So the final result at the end of the procedure was that's the part and the kissing there, and the part of the LMCA, and then you had a final decent result with good flow in both vessels. So he was hemodynamic throughout. Everything went off well. Only unfortunately there was a 250 ml contrast. Imaging was not done. 24 hours later developed aneurysm and acute kidney injury. Fortunately recovered with 1 sitting of hemodialysis. And this is his follow-up EKG after 3 months, doing well with a near normal LV function. So there are a lot of areas which needs to be discussed about culotte and DK crush. Many people think that it's difficult. The DK crush is a really operator dependent, but culotte is equally important, that you need about 3 parts there. And of course, many people feel that the outcomes are less with DK crush. But if you look at the EBC main paper, you would see see that there are a lot of arguments to and fro. And in Europe, it's worth remembering that 53% of the cases, when they use an upfront two-strand strategy, it is culotte. And I think imaging is equally done in both. And I think this is an idea which is propagated by the DK Crush in ABCMA, and I'm sure Professor Bahulayan will discuss extensively in it. So the final take-home is that both are available strategies. When two stents required, no penalty if results are optimal. And all these imaging are definitely useful, but not a must. More attention should be paid to optimizing the chosen technique than to choosing among techniques. And please go ahead with techniques which you are very familiar with. Keep it simple, swift, and safe. Thank you.
Oh, wonderful, Jagopal. I have a question to Dr. Madhu. You are actually planning to have a stent from the left main into the OM1. Am I right? Initially, according to your plan. But there is a considerable size mismatch between the OM1 and the left main. Dr. Madhu, are you there?
Dr. Madhu, you are muted.
Dr. Madhu, you're muted.
Yes. Sorry, I get.
We can hear you, yeah.
We can hear you, Dr. Madhu. Yeah, please.
The connectivity.
Okay. And you did not cross into the OM1.
No, I did not cross into the. At that point of time, the circ actually had progressed. So the point was to get the circ intact. I think that was the main vessel which was involved. And again, the one thing which was missing on the angio was the tiger went in, so the ostium was not very well profiled. So next time when you took him for intervention and the caudal, it was very clear that there was a tight oscillation. So that had to be covered right from the ostium into the, and crossing into the left main from the into the LAD was easier. So that's why I thought maybe culotte subsequently. And I'm very familiar with culotte. I keep doing this time and again.
That is okay, but putting one more wire into the OM is an ideal situation in this case because of the OM was very significant, especially the OM1.
True. I agree with you. The point at this time in a hemodynamically unstable patient and going through this angina, he was taken as an ACS in pain. So a lot of things. We were more concerned about getting the circ and the LAD back.
If we put a wire in the OM1, definitely we will end up dilating it and stenting.
True.
Was the first injection during your PTCA procedure provided to Madhu?
Sorry?
Was the first injection of your PTCA procedure with a guide catheter provided to Madhu? Was it provided to Madhu?
No.
See, I personally feel that the circumflex was so big, the OM was much smaller. I would have adopted the same strategy that you said. And probably at the end, if the OM, I would have probably done a POBA. My stent will be into the circumflex proper and definitely not into the OM because the circ was far more bigger than the OM1. There were a lot of branches of the OM thereafter.
Honestly, I thought...
There is an issue there because the OM1, if you see, it's quite big distally. And the problem is that the circumflex, it looks big in the proximal part, but the distal part of the vessel is, it's probably equivalent to OM1. And if you have put a stent into the OM1, you can always open the stent struts into the main vessel. But here you have an OM1 which is diseased from the proximal to long segment. So, it's okay, but finally in an emergency, whatever was done is fine.
But actually keeping a wire into the OM1, keep it provisional for the OM1 is always a choice in this case. As Madhu told, but angiographically I also feel that OM definitely should be preserved.
No, but see, I think...
whether not the LM to OM, I may not choose.
Because
I think there is a beautiful paper by this by Park Group. See, they say they always classified each vessel according to the myocardial mass, and any circumflex, whichever is non-dominant, this is always subtends 20% of the myocardial mass. I think Dr. Bahulayan knows about this. While any ramus or an initial OM is less than 6 to 7% of the myocardial mass if you have got subsequent OMs. So therefore, ramus or an OM should never be touched in an LM bifurcation.
How would you have done this? Would you have
done exactly that you did?
Professor Bahulayan, sir, your comment, sir?
Yeah, I think both the operators have to be congratulated. The one is the real operator is Jai Gopal, and the case is a critical case, acute coronary syndrome, LV ejection fraction is 35, severe left disease with multivessel involvement. I think the technique which we have used as Collot is familiar to you. That is number one. I think you stick on to that in this particular case. That is, Collot was more familiar, as we have confessed. And second is that Collot, by any reason, if you are familiar with, it will take lesser time, lesser strain rather than a DK crush in this situation. And that rightfully you have put it into the circumflex rather than into the first point. Those things I certainly agree with you. My only question is that this phase, if you have at least an intravascular ultrasound imaging with you, then you can be perfectly sure about the final result of your procedure. That's another one. Did you not think of putting at least an IABP in this case with a low ejection fraction and acute coronary syndrome with a complex disease, or is it not necessary? Some discussion on that.
No, sir. When I took him up initially, I was fairly certain that he would come because blood pressure was about 120/80, and he was comfortable at that point in time. Though he was having chest pain, he was not crashing at that point of time. So I did not. I mean, it was there ready in case it was required. But then I thought I would easily get away with that without that.
Sir, in Collot technique, is there how much stent overlap should be there? Because
as minimal as possible. That is a rule. But then here, the issue was, in fact, the left main was, it could easily accommodate a 6 millimeter stent. But then the problem was actually the ostium was involved. So you had to cover the ostium here. So, I mean, that bit of an overlap is something which you need to accept.
There's a lot of calcium which can see even before the procedure, no? A lot of calcium there.
Well, on fluoro, it was not so bad. I mean, I never did ever feel that, you would need anything more than...
Final shot, the OM, how is the OM?
It's feeling well.
Oh, very okay.
Feeling very
But
well.
actually, by the first angiogram shot, I was thinking there is a lot of calcium. Probably you may be requiring a rota. I was thinking how to do rota. That was my thinking, the rota. Then actually, I wanted to tell you that by doing rota, people think that plaque shift will be there. No. You can easily do a rota in one vessel and vessel and other vessel. There is not a big issue. That people should not think that rota cannot be done. In this case, rota you can do you should do a rota to the toughest vessel and then finish it off. That is the only thing I just wanted to tell.
Thank you for the wonderful.
Even not only the multiple wires, even the angulation is not a contraindication for doing a rotational atherectomy. Now, if you keep the wire in the LED, the wire could be protected with a microcatheter, and then you can do the rota on the circumflex.
But sir, even then, basically, if you do a rota, your rota burst should start from that ostium only. Otherwise, it may
could
come
be
down.
done.
That's the point.
Yeah.
Thanks for the wonderful discussion. I think the day is made.
Okay, thank you, Dr. Jayagopal, for the beautiful case. Now we go to the end of the last talk of the session, current management of LMCA bifurcation and overview by Baulen sir.
So it is already recorded. Dear chairpersons and friends, we shall have some discussion on the current aspects of left main stenting. This patient came for PCI, has got a distal left main bifurcation lesion, severe stenosis. He had received a stent in the proximal LAD circumflex a few years ago. He did an intravascular ultrasound, pulled back from both LAD and the circumflex was done. What are things we are going to find from this? Number one is you will find that the ostia of the circumflex as well as the ostia of the LAD are widely open. So there is no stenosis in the side branch. Regarding the morphology of the lesion, and at the lesion site you get calcium. And it is roughly around 180 degree arc. And it is a superficial calcium and probably thin calcium because you find the reverberations. So you can manage this calcium with the NC balloon. And we also get an idea about the proximal reference as well as the distal reference. Here the proximal reference was 4.5 millimeter and distal reference is 3.5 millimeter. We measured the length from the proximal reference point to the distal landing reference point, which gave us 26 millimeter in this case. So a provisional strategy was adopted by placing a stent of 3.5 based on the distal reference size and 26 millimeters when it has been deployed. And then the pot balloon was sized to the proximal main vessel, that is the left main, which is 4.5. And then a port was given at the placing the balloon at the carina. Pulled back again at the proximal portion, the stent was dilated at high pressure. Post PCI was, you look at the stent, it is well post expanded and there is no edge dissections. And minimal stent area in the left main is 15.5 millimeter square and LED it is around 11 millimeter square. Is very well acceptable. And the polygon of confluence at the carina point, one has to see that there is no malapposition at the carina, and a short, you can see that the carina at the circumflex opening is wide, and the only thing is that the jailing pattern of the stent struts across the circumflex is not very well made into the iris. Here OCT has got an advantage, it could show the jailing pattern across the side branch, and this is the result of that provisional stenting. Absolutely acceptable result. Now, this is the end of that procedure. But if you find that there is a side branch compromise, then you have to recross and then do something for the side, compromise the side branch. The recrossing has to be done through the distal stent structure in portion stenting by pulling back a wire from the main branch. You can use a new wire and then pull back, and by the pull back technique get into the distal stent structure to the side branch. And then of course you do the kissing the fish. So that technique is one of the common technique which is adopted in case you want the stenting of the side branch while the provisional stenting. And this is the steps of tap technique. You have to perform the provisional steps perfectly up to the kissing balloon inflation. And then you select the side branch stent, place a balloon in the main branch and inflate it, and the side branch stent is to be positioned. Very accurate placement has to be there. It should cover the side branch or stent, but it does not project much into the main branch. And once you deploy that, then you pull back the balloon in and then give a dilatation, and then make the side branch balloon align with it and say a kissing balloon inflation as it is shown here. Then port is repeat port is not mandatory in TAC technique. Now this case is, you can see that there is a distal severe stenosis of the left main, and then the stenosis of the ostium of the circumflex. We are not sure whether about stenosis of the LED ostium is there, but the IVUS, you look at the IVUS. You pull back from the LED, you find that there is a significant eccentric plaque opposite to the origin of the circumflex. So the LED is also involved, which is not made out in the angiogram. Here again, the proximal reference and the distal references are carefully made out. Interesting thing is that the distal references are different. In the LED it is around 3.5, and in the circumflex it is 4, and left main is almost 5. So a stenting has been done from left main to circumflex, followed by a port, and then dilated stent struts of this stent into the circumflex, and the side branch stent has been placed at this point. Stent boosting can be utilized to the correct placement of them, and then the stent is deployed and followed by a kissing balloon inflation in the port. And this is the result verified by the IVUS. Again, a good result in the sense well post expanded stent struts. This is the carinal portion. This is the very short carina, which is actually not compromising either the orifice of the circumflex or the main vessel. And you can see that the thin layer of this carina tip over here. And main stem, the minimal stent area was around 14 millimeter, and the lady was around 8.5 centimeter, which is quite a good result. Angiographically also it is acceptable. More important is that you have to verify the IVUS that the results are quite good, especially the no malapposition happening at the point. Now, what is the challenge in TAP technique? How to reduce metallic neocarina? So you have to cover the ostium of the side branch, but not much of stent projecting into the vessel. First thing is that do all steps of provisional stenting perfect as possible, and side branch placement after kissing balloon inflation of the main vessel stent. This is an important step. After kissing balloon inflation, this stent boost shows that the side branch ostium is actually partly covered by the struts of the main vessel stent, and you can see it in the fluoroscopy in the stent boost we use, and then the placement of the side branch stent can be nicely placed here. You should also know the details of the side branch stent, especially with regard to the balloon marker and the stent. Some of the stents, the stent may be crimped at the balloon marker. Some may have a gap. So these points can be utilized to clearly place to cover the ostium, but not much projection. Such. Have the polygon of confluence as wide as possible while you are doing the provisional stenting. You use appropriate sized balloons for the kissing balloon inflation and go to the appropriate height of kissing balloon inflation. What is recommended is that sequential higher pressure followed by a simultaneous kissing balloon inflation with a moderate pressure. And visualization of the bifurcation angle in different views is very important. You have to use different views for the anatomy which you are dealing with and find out the bifurcation point. Basically, that will help you proper placement of the side stent. Now, the DK crush is an important two-stent technique which is widely practiced nowadays, but it's quite good and it has been found even superior to culotte in left main as well as in non-left interpretation. But few features have been noticed after Professor Chang from China has described it. The first important problem is that the side branch stent is selected based on the distal reference vessel size. And side branch vessel tapering phenomenon is there. And once you place at nominal pressure this stent, you don't go for higher pressure because you don't want to avoid distal dissection. When you place nominal pressure, you will find that the side branch ostium, the stent is malapose and under expanded. And then you crush that stent, the crushing becomes unpredictable and therefore leading to difficulty in crossing through the crossing nicely into the side branch without crossing through the stent struts. The green line is actually the one which you should get, but the pink and the red are substrut level, and if you proceed with these wire positions, then it will result in crumping of the stents over there, the bifurcation. Now, Francisco Levara has, to this point, put forward certain alterations or changes, which has been accepted by EBC recently. What he suggested is that the side branch stent we deploy and then we pull back and give a dilatation here with nominal pressure as the first stent. But don't stop with that. Take another balloon of NC balloon of 0.25 to 2.5 millimeter larger, and then put a high pressure dilatation at least 18 to 20 millimeter over there, ensuring that the stent is well expanded and then there is no malpositions, and then you for the crush. You will find that when you do that, the under expanded side branch ostial area has really expanded very well. And the second alteration which is suggested, the crushing of the side branch stent. You should use a balloon that for the port based on the main vessel, the proximal main branch. That is, in this particular case, you find that a 4 millimeter NC balloon, and stent boosting helps you to see the side branch, and this balloon to crush is used as a pot type of technique. You can see that the balloon tip is at the carina flow divider, and then go to 20 atmospheres, higher pressure, and you will find that the stent is very well crushed. The stent struts are expanded over the side branch. It takes a concave shape and it becomes a monolayer stent struts across the side branch, enhancing your wire recrossing nicely. Here you can see the side branch ostium is covered with widely expanded struts, whereas proximal portion is the crushed stent struts. Here you need not necessarily go for the proximal stent struts, and in the usual type of situation you find that stent may not be very well crushed, and you are trying to search for the proximal cut strut, you can go underneath the stent struts. Here a non-distal stent strut can be chosen, and then space for the wire manipulation in the main branch is also higher. So this is the stent strut across the side branch. You can cross through nicely to the side branch, and the procedure becomes easier. That is that changes have been accepted actually, and people have started practicing it. Now the culotte technique is another important two-stent technique. This particular case where you have the Medina 111 lesion, you have utilized the CT to size the stent sizes and then the length of the stents, and then it has been done under the classical technique of Pilot. You'll find that post-procedural, the main stent area from the left main, the LED pulled back as well as the circumference fell above 8, that is quite good. And the polygon of confluence is also nicely expanded without much malposition. But when you come to the circumflex ostium, you find that it is under-expanded and then malposed. And that is not a good result actually. So we have to go with the higher pressure allocations and to get the result like this. What happens is that after the side branch stent is, the first stent is placed, you proceed with the port and then try to take the stent into the main branch. While you are manipulating that, you can distort the stent which was placed into the circumflex. To counteract, there is another section which has been found, that double kissing culotte technique. In this. What is double kissing culotte? Here again, you introduce one more kissing balloon condition, the balloon dilatation, the early phase of the procedure. After placing from left main to the side branch, you make a port, and then you do a kissing balloon inflation of the side branch and the main branch with the appropriate size balloon, ensuring that the stent in the side branch is very well expanded, very well opposed with the ostium, and it is unlikely to get tampered while you are manipulating the stent with the main branch. The result, you can find that the side branch stent is very expanded and very nicely in this cartoon. And therefore first kissing balloon infusion helps to maintain the side branch itself during main vessel preparation and stenting, enhancing side branch axis for final kissing balloon infusion. This is one of the recent recommendations. So I would conclude that left main bifurcation PCI is a viable option, and in most cases a stepwise provisional approach is preferred. Two-step technique like T and tap, decay crush, culotte could be considered in complex left main bifurcation lesions. High pressure ostial bifurcation lesions should be done. This is very important. You have to see that the ostiums is really expanded very well. There may be calcium. You have to take care of that before you place the stent and expand it. And the kissing balloon inflation of high pressure sequential followed by the simultaneous kissing balloon inflation helps this point. Port and final kissing is essential in two-step strategy. Probably in TAP may not be required, but all the other maintaining techniques should require two-step. Imaging, very, very important. Should either intravascular ultrasound or OCT. Or in certain cases, you may have to use both in case you have the facility with you. May appear as luxury, but it saves the situation. So imaging enhances the procedural success and reduce the image site. Thank you very much for your patient listening. Thank you.
Thank you, sir, for the extensive coverage of the topic. Can I ask you one doubt, sir? In your experience, how do you approach a left main to LAD crossover stenting? Whether will you do a kissing, will you cross into the circumflex and open the ostium, do a kissing balloon dilatation, or just leave it like that?
Right, I see. Generally speaking, in the case of left main, unlike the non-left main bifurcations, people continue to do the kissing balloon inflation. But in my practice, if the result is quite good and the side branch ostium didn't have a disease in the beginning and the flow remains okay without any pinch, I accept that result angiographically. But when we do the imaging, if we find that the jailing pattern of the side branch could be a point to go ahead and do a kissing balloon inflation. If you have an unfavorable jailing branch, especially a linked carina, it is better to use a kissing balloon inflation to separate the stents out of the side branch ostium. So that is the pattern I follow in my procedure.
There is also a possibility that if there is a lesion, new lesion developing in the circumflex later down, then it may be difficult to dilate the struts at that point of time, because there may be the linked carina will be difficult to dilate. Sometimes it can even be resistant to dilate.
Yeah, that's very true, Saji. That is why if you have at the first index procedure, if you have an imaging facility with you, you can definitely address that issue which can arise later.
Sir, a wonderful presentation. Sir, I have one doubt. So, regarding the port in provisional tap technique, if there is a little more protrusion into the main vessel, that port will produce more because there will be again crushing and it will produce more problem. So, what is your opinion regarding that?
Yeah, there are two ways of looking at it. You have in any way have to give a kissing balloon inflation. So for kissing balloon inflation, you have two balloons, one based on the main branch and the other based on the side branch sizing. And that, the combined portion of the balloon projecting into two balloons, projecting into the polygon of confluence will be as short as possible. So maybe one could say that if you have a left main, it should definitely be lesser than 1/3. That is one way of looking at it, and then avoid totally a second port. But you can still perform bots if the proximal stent is longer one. Only thing is that you should not go deep. You should keep away from the carinal point where you have both the side branch stent coming into that point. And stent boosting definitely helps this point. You can clearly visualize the stent coming into the main branch, and then the second port balloon can be placed proximally and take care of the proximal portion of the stent.
Port is not mandatory. We can avoid the port in.
Yeah, that is why you can avoid the port if you do the kissing balloon inflation like that. Only confining the proximal combined portion of the balloons to the polygon of confluence.
Ronnie, any comments? So I think we have exceeded time. Thank you, sir, once more. And with that, we come to the end of the session. I'd like to thank all the speakers and all the audience for participating and making this a very fruitful session. Thank you very much. Over to Jacob.
Thank you.
Thank you, Dr. Saji. I think that went off very well. So now we have the next session which is coming up, where we really look forward to our President's lecture. So may I have the pleasure of inviting the chair for these sessions, Dr. M.N. Krishnan, who has flown in from Abu Dhabi just for this. He was supposed to join us, but I think last minute he wanted to be online. So I hope he's there. Can we see Moses? Can we have them here? Professor Taragan, Dr. Jagmohan Taragan. Yes, sir. And Dr. Ramakrishna Pillai. Thank you, sir, for being here. So I think without wasting much time, let me hand it over to the chairperson. So over to you. It's nice to see so many people. I think we should be doing it. It should be like this. The thing is just the name. No, when you see the mobile, it's not the name.
Yes, sir. Yeah, doctor. Dr. M.N. Krishnan or somebody else will start?
I joined earlier.
Okay, shall I start then? Who wants to start? Professor, please.
Timer, Moses.
Okay, I will start. Dear friends, along with my co-chairs, am I audible?
Very much, sir, very much.
Am I? Okay.
Yeah, very much.
Along with my co-chairs, Dr. M.N. Krishnan and my dear friend, Dr. Pillai sir, very warm welcome to you all for this very important scientific session, the presidential address by Professor K.U. Natarajan, President ICCK. Professor Natarajan needs no formal introduction to this august audience, having led the ICCK from the front during his tenure as the president. I personally consider it a great privilege to be part of this scientific event. Dr. Natarajan, beyond being a great friend of mine, is a wonderful gentleman, an exemplary human being, an academic teacher, researcher par excellence, skilled interventionist and electrophysiologist, all molded into one. And that makes him one of those few accomplished cardiologists of our times. So he is going to talk to us on, do you always need imaging in calcific coronaries? Over to Professor Natarajan for his presidential address.
Thank you, Taragan sir, Krishnan sir, and Pillai sir. I've learned a lot from all three of you. You have been my teachers at some stage of my life. And I'm extremely happy that I'm going to give a little contrarian view on a rather complex topic like a calcific lesion. The question put is, do you always need imaging in calcified coronaries? We have had a flurry of cases in today's presentations, and most of the cases actually needed imaging, or imaging was done in those cases, with a few exceptions like the one which our scientific committee chairperson, Dr. Jayagopal, he didn't do. Rajesh Muralidharan in his SKS, he did not do. I could finger count the cases where imaging was not done in complex cases. So I'm very happy that the chairpersons all were very veteran interventional cardiologists and have phenomenal experience in the pre-imaging era. So with that background, we will answer this question. Is imaging always needed in calcified coronaries? Most of you in the audience will say, of course it is needed. Let us look at it a little differently. If you look at the SCAI classification of clinical, anatomical and procedural domains of complex PCI, as I have highlighted, calcified lesions are indeed a complex anatomical subset of coronary artery disease. How does this become severe? More the calcification, more the extent of coronary atherosclerosis, higher burden of comorbidities like diabetes mellitus, elderly age, CKD, post-CABG, so on and so forth. So calcification means you are dealing with a real complex lesion subset. Treatment of severely calcified lesions is complex. It increases the risk of incomplete lesion preparation. That's the most important thing. Suboptimal stent deployment is a consequence of poor lesion preparation, and this leads to higher rates of not only acute, also chronic stent failure in the form of restenosis and target lesion failure during follow-up. Imaging has a pivotal role in calcific lesion subsets, as we have seen throughout the length of this conference. There is significant histopathological and imaging correlation of calcification with IVUS, OCT, radiofrequency, IVUS, virtual histology. So there is no question that imaging is very, very useful. If you look at the comparison of the varying modalities like coronary angiogram, CT, IVUS, virtual histology, IVUS, OCT, coronary angiogram is the least important. You only see single plus marks with regards to detection, localization and quantification. And my talk will focus on the value of angiography if you pay enough attention to minor details in the angiography so that you can reasonably bridge the deficiency between the angiography as it is perceived today in comparison to the imaging modalities. The angiography has a host of things to offer, provided we are willing to spend time on the angiography and look at more critically. And all these studies have shown that all endpoints are superior when you use imaging in complex coronary interventions, whether it is MACE, thrombosis, all-cause death, cardiovascular death, etc. Imaging clearly makes a difference. If you look at this angiogram, this is an RC angiogram. I'm just running this for you. You see something very dark here? That is actually the LED. I have zoomed it and I have frozen it for you. This is just an angiography. If you now ask me the arc of calcification here, it is obviously close to about 270 degrees. So this is an end-on view of the LAD that was seen in the LO view of the RCA angiogram. So if you pay attention to such minor details, you get a lot of information from the angiogram which has been pushed to the backside with the advent of imaging. If you look at this algorithmic approach for optimal management of complex calcified lesions, imaging forms a major tool in assessment of lesions with regards to the arc of calcification, the length, the thickness, etc. And the entire subsequent way we treat calcified lesions depends on what we find in the angiogram, provided we are able to cross the lesion after pre-dilatation, so on and so forth. So there are various technologies to combat calcium. As we all know, the rotablation is the time-tested one, the cutting balloon, the high-pressure inflation balloons like the OPN balloons, the lithotripsy, orbital atherectomy, telescoping catheters give you more access to calcified lesions with stenting. Even with the imaging catheter having difficulty in going, you can use the telescoping catheter to actually take the imaging catheter to target, and also the ELCA laser, which is currently available in our country. So, accurate definition of patterns of calcification by intravascular imaging, in addition to the tools like rotational atherectomy and the newer technologies, go a long way, and they undoubtedly herald a change in procedural algorithms for the treatment of severely calcified coronary artery disease. We don't have any debate over this. Imaging definitely makes a difference, and it is helped by the newer technologies of treatment. However, coming to the topic proper, imaging may not... Did we start with 15 minutes? However, imaging may not always be feasible for the following circumstances: emergency situations like primary PCI, unstable hemodynamics, failure to cross with the imaging catheter, inaccessibility to imaging in a remote center, cost factor, which has to be considered in a cost-conscious country like India. So in the absence of imaging, how best to perform PCI in calcified disease? By sticking to basic principles on the basis of angiography,
will be the focus of my talk, and I will show you 2 case examples to highlight this point. Case number 1 is a 66-year-old male, diabetic. He underwent a cabbage in 1996 with lima to the LAD and venous grafts to the OM and RCA. He had a cirrhosis liver. He presented at NSTEMI in 2014, many years after the CABG. He had native triple vessel disease. The lima was fortunately patent. He had occluded venous grafts to the LCX and RCA, and there was a 90% LCX stenosis with extensive calcification. He was taken up for PTCA to the LCX with the rota backup. This case I am showing for the limitations of not doing a proper pre-dilatation. So this is the critical disease in the circumflex that you see here. I have just frozen this frame to show extensive calcification, which we often see in post-bypass surgery patients. So we took a 1.25 into 15 millimeter balloon, we dilated, a 2 millimeter was partially crossed. Of course, it did not dilate fully, as you can see here. There is a dog bone effect. So we, as planned earlier, we took a 1.75 millimeter burr and we did rotational atherectomy, as you can see here. The burr crossed, and this is the post-rotational angiography that you can see here. The lesion has definitely been modified to a large extent. Then we pre-dilated with a 3 into 15 millimeter balloon. I underlined 3 into 15 millimeter balloon, whereas the vessel I thought angiographically was 3.5, and I took a 3.5 into 38 millimeter DES, and this is the stent being deployed. The stent tracked very easily, but you can see that there are areas of under expansion, as has been shown by these red arrows. We post-dilated with the 3.5 into a 8 millimeter non-compliant balloon at high pressures. This was done about 7 years back. And this was the final result. It is not satisfactory. And this is the maximum that you could achieve that particular day. And in today's time, all of you will agree that there is some suboptimal stent deployment. And as expected, 9 months post-procedure, this patient came with recurrence of effort angina. And you can see that there is a significant disease in the area where we had the suboptimal stent expansion, and we treated it with a drug-eluting balloon, etc., which I will not go into because that is not the topic right now. So the lessons learned in this case are, this was a clear demonstration of a poor lesion preparation. And the final pre-dilatation was done with a balloon which was smaller than the eventual stent that I put, 3.5 millimeter stent, but the final pre-dilatation before the stent was with the balloon which was 0.5 millimeter smaller than the stent that I proposed to use. And this patient had a target lesion failure on follow-up. So these are the lessons that was learned from this case, which was done about 7 years back. Moving on to a more recent case, a 75-year-old man with multiple comorbidities, severe ankylosing spondylitis, and an old inferior LMI in 2001. 15 years later, he came with an NSTEMI, and the RCA was chronically occluded. The LAD had a mild disease at that time, and he had a critical disease of the circumflex OM. He underwent rotablation stenting of the circumflex, and he was doing very well for 5 long years. He presented not in October, in last month actually, with elevation of troponin. He came with an NSTEMI. We thought it could be a circumflex failure like the previous case, but that was not the case. And we took him for an angiogram. Again, the RCO was CTO. It was collateralized. The circumflex stent was widely patent this time. There was a tight stenosis of the LAD which was not there in 2016, and there was a borderline disease of the left main, and the patient was unwilling for surgical revascularization. You can see that there is extensive calcification on the angiogram. I hope you can see it on the pictures. There is no brainer that there is significant calcification, and it is likely to be deeper calcification in this patient given his age, given his old CABG status. It is likely that there is extensive calcification and probably deeper calcification. And that's the angiogram. You can see that there is some borderline disease of the left main that you see here. The circumflex is patent. This was where the critical lesion was in the 2016. And you can see that there is LAD disease as well. That is the LAD disease here. So the initial plan in this case was, there is densely calcified lesion from the proximal to mid LAD. So we thought we'll initially pre-dilate. If the balloon does cross and expand reasonably well, we thought we will do a lithotripsy to prepare the lesion well. If If the balloon doesn't cross or expand, we'll always have the backup of rotational atherectomy. Then we will image with the OCT for adequacy of lesion preparation, severity of the left main stenosis, to better size the vessel, and to stent the LAD right from the ostium, and post-stent optimization with the repeat imaging, and if the left main is significant, to do a PTCA to the left main as well. This was our original plan. So this is the angiogram. This is a 7 French extra backup catheter through a femoral axis. We use the opaque part of the wire to measure lengths, not necessarily with imaging. Opaque parts of the guide wire is 3 centimeters. You can use an Oxford balloon also to measure length. So length can be measured by non-imaging techniques as well. And we dilated the LAD here with a 2.5 15 millimeter semi-compliant balloon. The lesion partially opened up, enough to at least take an IVL balloon. We took a 2.5 into 12 millimeter IVL balloon, and unfortunately with very the balloon ruptured due to calcified spicules, which makes it a case for considering having a lower threshold to do a rotational atherectomy before taking an IVL balloon. And when the process of removing the ruptured balloon, you can see that the guide gets telescoped badly. Such a gritty feeling in this area that the guide telescopes badly when you remove the ruptured IVL balloon. So the IVL balloon ruptured. This is the picture after the IVL balloon ruptured without dilatation. So in the very first pulse, the IVL balloon ruptured. Already we are pre-dilated to the 2.5 semi-compliant balloon with a reasonable expansion. So it's very unlikely that the calcium is superficial. The calcium is likely to be deeper. And a rotational atherectomy at this point may not make much difference because the 2.5 balloon reasonably opened up. So what next? So we took a 2.5 into 10 millimeter Wolverine cutting balloon which expanded reasonably well. We did serial inflations with the 2.5 millimeter cutting balloon. And we took a 2.75 into 12. We thought it was a 2.75 millimeter LAD. So we took a 2.75 millimeter balloon to do the final pre-stenting pre-dilatation. That's what I wanted to highlight. Always take a balloon with a 1:1 size to the stent that you propose to use as the final pre-dilatation pre-stenting. And this balloon opened reasonably well. We checked in multiple views. This balloon reasonably opened well, and there was a dissection. Dissection is a favorable sign that you have actually modified the calcium. So this is the stent being positioned from the ostium of the LAD, covering the entire disease segment. There is a bad bend in the LAD there. The stent reasonably expanded. Then we post-dilated with a 3 into 12 millimeter non-compliant balloon. That is a stent boost. Stent boost again helps us in the angiography without imaging. And the 3 millimeter balloon also reasonably opened well. So that is the final inflation at the ostium. And throughout this procedure, we had very bad ventricularization. And if you see this angiogram carefully, in comparison to the size of the daughter vessels, the LAD and the circumflex, the left main is smaller. Whenever there is ventricularization, damping of pressures, and the LAD is smaller than the daughter vessels, it is an indirect angiographic pointer to the fact that there is left main disease, even without imaging. So there was repeated ventricularization, so we thought we'll proceed with the left main angioplasty. And that was an easy exercise, 3.5 into 8 millimeter pre-dilatation, 4 into 8 millimeter pre-dilatation. We took a 4 millimeter onyx stent and we post-dilated with a 4.5 millimeter balloon. And that is the final result that we got in the left main and in the LAD without compromise of the circumflex ostium. That was the final result. So the points to highlight in this case are, things don't always go according to plan. The IVL balloon bursting was a setback, and which in my opinion is not an uncommon event if you do not do prior atherectomy. The use of a cutting balloon as a bailout in preference to rotational atherectomy, because already we have pre-dilated the 2.5 millimeter balloon, which gives you a rough indicator that there is deeper calcium in the absence of imaging, and rotational atherectomy is unlikely to offer further incremental benefit. Every balloon exchange in this case was very challenging, gritty. The guide will telescope, and we knew that it is a bad disease, and that's why we got a little discouraged. I'm sure some of you in this audience will tell that you can always take a guide extension catheter and still do imaging, but we thought that we will avoid imaging for the reason that I already told you. In the absence of imaging, I want to highlight the fact that every step has to be near perfect. If you base your decisions on angiography, measurements using opaque part of the wire, balloons for precise lesion, stent length assessment, and the decision to do left main PCI by the dampening, comparison with the daughter vessels, etc. are crucial steps. And of course, stent boost images will help us to ensure reasonable stent expansion. The most crucial step to ensure near perfect results in severely calcified lesions in the absence of imaging is adequate lesion preparation before venturing into stenting. Stenting is the last step. Stepwise use of gadgets, and finally pre-dilating with a non-compliant balloon of the size matching to that of the proposed stent in a 1:1 fashion is an useful idea, and this should be followed by adequate post-stent apply. So the question asked was, do you always need imaging in calcified coronaries? And the caption which the scientific committee chairperson gave was, will you trust the eye or the camera? I will certainly respect the camera that is imaging, and sorry. What the eye sees in the angiogram, provided all finer informations are looked into minute, great detail in the forgotten angiography in the post-imaging era, in a manner that it must be seen, makes a reasonable alternative to imaging. May not be a real alternative, at least something closer to imaging as possible, and that for that particular reason, I will trust my eye as well, as much as the camera, if not more than the camera. Thank you very much for your kind attention.
Thank you, Professor Natarajan. I don't know whether the presidential address is followed by any questions or queries from the audience. There is nothing in the chat box I can see. Professor Pillai, any comments?
I just want to say that it is a pleasure to be with Dr. Natarajan. Am I audible?
Yes, sir, very much, sir.
Please go ahead.
It's a pleasure to be with you and to listen to your talk. In this topic that you have chosen, there is a trade-off between the ideal and the practical. Are we hampered by certain practical issues in not using imaging? Often we are. And the two factors are time and money. But we have shown that in the course of years, your procedure has improved a great deal. And if imaging was also there, it would have probably improved further.
I think Dr. Natarajan, I was reminded of Professor Bernie Mayer saying that he doesn't believe in imaging. He doesn't have the luxury of spending money on imaging. You know, one of the big guys who worked with Henry Grunzig. So I think he still believes in that. So I think there are a lot of people who would really...
No, we do a lot of imaging in our center.
No, I'm not talking about that. It's in a different world altogether.
I just wanted to give something contrarian to what is
different perspective.
Just for the variety. Variety is the spice of life.
Professor M.N. Krishnan, please. I think we will look forward. I mean, your comments, sir.
I agree with Natarajan. I think your talk was excellent. A real presentation. As you mentioned, you have to be effective. There's nothing routine, anything that you do in practice. You have to go by case, select the case, and whenever it is required, you have to not do it. That's what has to be done. Thank you.
I also would tend to agree with Dr. Natarajan. You have forgotten the art of doing a perfect angiogram and a perfect angioplasty. But I also beg to differ from you entirely, because I think imaging makes life much more comfortable.
Imaging definitely makes a difference, but angiography also should be looked into in greater detail.
Absolutely.
You can bridge the gap between imaging and not imaging. That's all I wanted to convey. So let's stop here.
Thank you, Professor Natarajan. We would like to thank all the chairpersons for active participation. Thank you.
Yeah, so it's my pleasure to have the next session. So the next session is called Rock-like Resistance. And we have the first talk by Dr. Srikala. She'll be speaking on unusual case of RCA ISR. But first, I hope the chairpersons have come in for the session. That's Dr. Anil Kumar, Dr. Balakrishnan, and Dr. Jabir. I think Dr. Jabir is here in the audience itself. So Dr. Jabir, please.
Thank you, Dr. Rani. It's a, what do you call, excellent caption. It's a rock-like resistance. I'm sure that our presenters are going to break the rock. So let me first invite our first presenter, Dr. Srikala, to present her case. Do we have our co-chairperson?
Good evening, respected chairpersons and senior colleagues. At the outset, I would like to thank Jay Gopal sir and Placid and all the members of the organizing committee for giving me opportunity to present this case before you. So today I would like to share with you a unique case of right coronary artery instant restenosis and the problems which we tackled during angioplasty. So the patient is a 56-year-old female with diabetes since 8 years, hypertension since 10 years, and she has a history of inferior wall end STEMI way back in 2006. For which she underwent angioplasty to right coronary artery in 2006 with cipher stent. The details were not available, and she was on regular medications and follow-up since then. Now, that is around 15 years after the event, she presented with effort angina class 2, which worsened over the past 1 month, and she had frequent episodes of rest angina, with which she was admitted to coronary care unit. She has no previous history of cerebrovascular accident or peripheral occlusive vascular disease. Her ECG at admission revealed a normal sinus rhythm. There was significant ST depression in inferior leads, 2-3 areas. She was stabilized with antiplatelet treatment and with low molecular weight heparin, and then she was taken up for repeat coronary angiogram. Her left system revealed only minor lesions. The LAD and circumflex was showing no flow-limiting lesions. And in the right coronary artery, there was an instant restenosis with the chronic total occlusion of the stented segment in the mid-RCA. There was also significant dampening and significant lesion of the osteoproximal segment and faint collateralization of the distal PDA was faintly seen from homocollaterals. I am sorry for the poor quality of the images. And we proceeded with the revascularization and using an AL1 guide, and with microcatheter support, multiple wires were tried and ultimately crossed with a run-through extra support wire, and I was played. The distal end of the wire was parked in PDA. And now multiple balloon dilatations were given for the entire stented segment using 1.5, 2, 2.5 and 3. And there was some amount of calcium in the stented segment. So it was pre-dilated. I also used a NC balloon. There was, since this case was done around 3 years back, there was no cutting, there was no option of this ideal balloon, and also the lesion opened up with an NC balloon. So with multiple, after multiple balloon pre-dilatations, flow was established in the distal RCA, and now the osteoproximal RCA was densed because there was a significant lesion in the ostium also. So a long stent of 3x38 revoluting stent was used from the osteoproximal RCA and covered up to the mid-segment. And this was the final angiogram, which revealed there was a good flow up to the distal vessels. So the take-home message is the ISR CTO is one of the difficult subsets of CTOs to revascularize. And here the drug-eluting stent restenosis was treated by another drug-eluting stent. The patient had relief of angina and she was symptom-free, and now she is currently on dual antiplatelet therapy. Thank you for the patient.
Thank you, Srikala. Great case. Only thing is, since you have some problem with your cine,
yes.
we could not see the running or the moving picture. That's the only limitation. Fantastic case. Balakrishna, would you like to comment? Balakrishna, you are muted. We can't hear you.
Yeah, I'm audible now.
Yeah, very well.
Okay. Srikala, wonderful case.
Thank you, sir. Thank you.
Only problem was that I was not able to see the live images, videos.
Balakrishna, she had a problem, so she could not run the images.
I have another problem because I am hearing my own voice. It's reverberating so much. I don't know. Anyway, tackling that problem. Srikala, you said CTO of ISR is, as you rightly said, CTO of ISR is entirely different from the usual CTO. Actually, do you find that ISR CTO is difficult to manage or easier to manage? Because most often it's a cheesy material and you have easy access across with slippery hydrophilic wires and not so difficult to open with balloons, usual balloons.
Yes, sir.
Do you had some sort of stent fracture or stent deformity? Was it producing the problem?
Sir, actually, I don't have any imaging in my center. Am I audible?
Yes, Srikala, you are audible.
The thing is that the same thing, I'm hearing my own voice, so it is reverberating. Okay, so in this patient, I didn't have much difficulty to cross the lesion. Since, as sir told, it was a cheesy material, and I used the regular NC balloon as well as cutting balloons. And I thought there is a stent fracture because I don't have any stent boost image. In the stent boost image, there was a stent fracture in the mid-segment of the RCA. And this stent was placed in 2006. It was a cipher stent. It was a first generation drug-eluting stent. At that time, probably there was a stent fracture, I don't know. And I don't have any imaging to demonstrate that. So probably stent fracture was there in the mid part.
It's 10 years, isn't it? 10 or 14 years?
14 years.
So it's 14 years, so there are two possibilities. Now, I am sure that you have gone through the new classification of the ISR by Waxman. He looked into the pathobiology, and one is the biological reason, other is the mechanical reason, or a combination of biological with mechanical reason. So there must be a biological reason, that is a neoatherosclerosis. That is why you could cross the lesion a little easy, and the final result is excellent. And this is one situation where imaging seems to be mandatory. Though we may tell that we are managing cases without imaging, you could get a good result without imaging. But imaging could have given us the understanding of the pathobiology, what has happened in the stent. And we would have loved to see the images of cipher after 14 years. How does a cipher look like? If you don't have an imaging, this is the way you manage. Another stent, or whether it is cutting balloon, but here your lesion, you could open up it very well with the balloon, so it's a balloon dilatable lesion. And if it is neoatherosclerosis, you manage it just like a de novo lesion. Another, this is the usual method by which you tackle this restenosis. So thank you very much, fantastic case. We'll move on to the next case.
Thank you.
Dr. Karanadas, could you present your case? Even one small puff can be deadly.
Respected chairpersons, senior members of the faculty, and dear friends, even one small puff, whether it be cigarette smoke or whether it be contrast media, can be deadly sometimes, as is shown in this case. A 70-year-old female with history of hypertension, effort angina, normal LV function and positive TLT, had angiogram from outside which showed an RCA tight lesion, and she was taken up for elective PCI in our lab. RCA was cannulated with 6FJR 3.5 guide catheter, and the injection showed a tortuous calcific vessel with a tight lesion in the proximal part. RCA was wired with cyan blue wire, and the proximal lesion was pre-dilated with 2x12 SC balloon at 12 atmospheres. The same balloon was pushed distally, and that part of the lesion was dilated, and then the whole problem started. We could see the dye extravasating. The balloon was removed, and a small check injection showed type F dissection with intramural hematoma, distal flow being cut off. The patient started complaining of chest pain with ST elevation in the ECG. Immediately, 2.5 into 24 DES was implanted distally, sealing off the site of dissection, and the proximal part of the lesion was stented with 2.75 into 28 DES overlapping with the first stent. Luckily, the whole thing sealed off, distal flow was re-established, and this is the final result. The patient settled down. We had a look at the balloon outside, and when we inflated it, we could see a pinhole rupture with the dye forcefully being projected out through the pinhole rupture. Retrospectively, looking at the first pre-dilatation, probably there was a small puff of contrast escaping, which was not noticed during the procedure. So essentially, we had a balloon rupture, a pinhole rupture, which led to a high pressure jet of contrast forced through the pinhole, directed at the vessel wall, causing the dissection and intramural hematoma. Balloon rupture can also be circumferential or radial, as well as longitudinal or axial. When we look at the causes of balloon rupture, they include reuse, oversizing, going above the RBP, and calcium spurs. In our case, it was a new balloon. We did not oversize the balloon, and the RBP was 14 when we went only up to 12 atmospheres. So probably it was a calcium spur at the site of lesion that led to the pinhole rupture. Summing up, the take-home messages include: even new balloons can rupture when inflated against calcific lesions due to spurs. Careful observation for even a small puff and avoid disaster. Once dissection is seen, further check injection should be minimal and done with less force. To avoid worsening. Quick sealing of the site can prevent propagation of the intramural hematoma. Thank you for the patient listening.
Thank you, Karanadas. Thank you, Karanadas, for that great case of yours. As you said, whether it is New York or Oxford, balloons can rupture, and it's beyond your control. It's something quite unexpected, and that high pressure jet has produced that dissection, which has cut off the flow, and patient started experiencing the pain, and you managed the case very well. There was nothing, and the final image looked extreme. What an excellent result of the stenting, and it's a horrifying thing after the balloon rupture. The dye was standstill dye. There was no flow distally, and the patient had pain. I'm sure you had a quite tough time at that time, but you could quickly manage it with great speed and with an excellent final result. Balashan?
Yeah, wonderful case. As you rightly said, the earliest detection of a small puff or a contrast filling downstream. Every time one should be seeing the fluoro whenever you dilate. Actually, this is really creating problem for me because there's reverberation.
If you remove that thing, why don't you?
My flow is being cut off right now.
Right.
Anyway, that you let the youngsters should note that every time a balloon is being dilated, you have to see whether some dye is getting into the distal pouch of the vessel. And as soon as you see it, deflate and never inflate it further.
This happens especially in calcified lesion. One part there will be calcium, one part there may not be calcium. And usually it happens when you go overboard, very high pressure. One side it dilates, one side it will not dilate, and it can even perforate the vessel. Even balloon dilatations can perforate in that situation. It's well managed. Any comments from the floor? If there are no more comments, I think we'll close down the section. Thank you very much for the two speakers. Wonderful cases, and we have learned a lot. Thank you so much.
Yeah, thank you, Dr. Jabir. Now we come to the most anticipated event of the day, and that's the big fight. We have got two giants from our state who are going to fight with each other, and we're going to enjoy every moment of that. And it's a debate on the Ischemia trial. So let me invite the chairpersons. Dr. Rajan Joseph Manjuran, sir, are you there? And Dr. Venugopal, sir.
Venu is traveling. I don't know whether...
Has Dr. Manjuran logged in? Manjuran sir undo? Ilya, he's not there. So in that case, I think the moderators are there. Dr. Johnny is there. I can see him. Good. So Dr. Sajeev is also there. So Dr. Johnny and Dr. Sajeev, can you take this forward?
Dr. Jody, please.
Hello, Sajeev.
You can start.
Okay, so who is speaking first? Mohan sir?
Dr. Johnny? Hello?
Yes?
Dr. Johnny, Dr. P.P. Mohan sir will be speaking on, despite the ischemia trial evidence, I would still perform interventions on most of my patients. Manjuran sir, you are there?
Yeah. Yes,
good evening, sir, to you.
You look very colorful, sir.
Sir, you are muted.
Sir, colorful.
Sir, you are muted, sir. Can you unmute yourself?
Muting.
Right, great. We can hear you.
Okay, fine, great.
Can you please take over, sir? Yeah.
Okay, fine. Good evening, everybody. I think after a good number of exciting and very challenging case discussion, we are coming to an interesting part of the session, that is a debate. Ischemia has got a special attachment. We have got very close to our heart because one of our centers provided the largest number of cases for ischemia trial. And I think Krishnan and his team especially needs a special congratulations for that. And so it will be very interesting that from the state of Kerala, two people are debating on ischemia trial. We all know that acute coronary syndrome, the management of obviously is intervention and revascularization. But for chronic coronary syndrome, things are not that clear. There is some controversy. That is why there are a number of trials like Courage trial, Orbiter trial, and now we have the ischemia. And based on ischemia, we have two veterans speaking to us, one for in favor, another against. Let's say what is their conclusion. So with that, let me first invite, where is Venu?
Venu may take some time, it seems.
Okay, so with these initial comments, I will invite the first speaker, Dr. P.P. Mohan, the CSI president, to present his points. So he says that ischemia trial, he is against ischemia trial. Let's find out his views. Mohan, the floor is yours.
Thank you, sir. Ronnie, there is no fight. Ajit is my dear good friend. Okay, so right. This is something all of us are proud of. We have Krishnan here, Balram, Bhargava and Murthy, three contributors to the fantastic trial. And Calicut Medical College contributed almost 19 to 20% of the India contributed maximum, more than 900 patients. And this was a trial which we have been all looking for the last 10 years. When it was conceived, maybe in 2010, it was not for equipoise. It was presumed that an intervention can help most of these patients with chronic cerebral angina. Of course, we had information from the previous trials about that. Courage and the Barry 2D showed revascularization may not be of benefit in terms of improvement in the death or MI. This is the patient flow. Just have to look at this, that there are a lot of exclusion criteria. Very symptomatic patients were excluded. ACS, of course. Recent CABG, recent revascularization. 1 year, okay? So NYHA again, class 3-4. Those who had LV dysfunction, those who had a GFR of less than 30. And there were a lot of, again, substantial number of screen failures. Initially, the investigators were hoping that they could recruit about 8,000 patients. That was the sample size. They decided for getting the absolute power, but then finally they have to be satisfied with about 5,100 patients. These are important points which may be, look at that. You don't need to worry about that. They are all very comparative, but this is something which will interest you. The angina frequency. See, no angina, 35%. This is maybe a little unfair to the. I don't think many amongst you will do a revascularization for a absolutely asymptomatic patient, unless you maybe if it's an LMCA lesion you may, but otherwise that is anyway. That is something which you have to give importance. There was again, apart from the diluting the primary endpoints by bringing in, now initially they started with 3 primary endpoint, then it was a 5 point primary endpoint. They brought in unstable angina and cardiac arrest. Maybe again, because of they were a little worried about the sample sizes. A figure from 8,000 to 5,000 can create problem. Maybe to mitigate that, they included unstable angina. And here again, in the qualifying stress test, there was again dilution. The exercise stress was brought in because of some compulsions, basically because not every center could possibly do the other imaging, and when they included India and China didn't recruit that much of an India. As naturally, it was difficult for the Indian centers to do other modes of imaging. But interestingly, 77% multivessel disease, and huge proportion of patients with proximal LAD disease. And during the course, this is what, again, now you could see that the medical arm, the OMT arm, it is essentially OMT versus OMT plus revascularization. Don't be under the impression. OMT is always considered an important entity. So during this period, about 23%, unlike Courage had about 30%. Here you have about 23% had revascularization during this follow-up of these patients. 28% underwent coronary angiogram. That's all. This is the mode of revascularization, 74% PCI and 26% CABG, 93% got arterial grafts, and amongst the PCI persons, 98% were using drug-eluting stents, quite unlike the previous one. But then the question about whether they were totally revascularized is something which we will see later. This was the primary, I talked about the primary outcome, 5-point primary outcomes, and you could see, in the initial time, there was some excess of procedural MIs, and when they were followed up, the end of 4 year, you could see a difference of absolute difference about 2.2%. But again, the sample size will not allow them to have any sizable statistical significance. But look at that, the curves looks widening as the years go by. It will be very interesting to see these ischemia trial data at the end of 10 years. That is another matter of speculation. The importance of these procedural MIs, which happens initially, which tilts the results adversely to revascularization, is another important point, again, which I will definitely spend a minute on that. The secondary outcome, again, there's no difference between the primary outcomes are appeared on that. So no significant difference between cardiovascular death and all-cause death. But then that is not great news. Now we have known all these. No differences in mortality was known to us right from Courage, Barry-2D, and the pressure-wired FAME-2 trial. So we are not talking about any differences in the mortality, and all the meta-analysis by Sripal Bangalore also showed us that revascularization may not decrease death or cardiovascular mortality. So we don't need to worry about that. This is something which is interesting. We have seen definitely at the end of the trial that there is a decrease in the myocardial infarction. There was an increase in the myocardial infarction procedurally also. How much importance do you have to give it? See, the debate was going on and on about the importance of procedural myocardial infarction. Is procedural myocardial infarction a real MI? And we have umpteen number of data which shows that spontaneous, the procedural MIs need not be given that much of importance. We have a retrospective analysis of about 3,000 patients, which showed that a multivariate analysis has shown that procedural MIs may not be that important. But then again, we don't have any I'm on a sandy ground here, so I cannot be very certain. But then that is what? It's also known that revascular, as shown in the ischemia trial, at the end of the trial, the spontaneous MIs were considerably reduced by the revascularization. That is again shown in very many RCTs, and this is just a meta-analysis of about 15,000 patients showing you that revascularization reduced spontaneous MI. So this is that. Though the confusion about that, the MI may persist, but then I presume that the procedural MIs may not be that important, but the later onset MI may be important. That's my argument. Ajit may have different. Now coming to the quality of life, the Spertus paper on NEJM and the American Heart Association, and this paper was presented on the next day of the AHA after Hodgman presented the final day. Whether you live longer or whether you feel better is an important question, but we will debate, go on and on. This study showed that though in symptomatic patient, there was significant improvement in the quality of life right from the beginning of the trial, right from the beginning. You don't need to wait for 2 years as you have seen for the disappearance of the MIs. In all symptomatic patient, 30% were asymptomatic. You can't expect them to be anyway showing any improvement. But in all symptomatic patient, there was improvement. I was mentioning about the completeness of revascularization. Look at that. Only 60% were completely revascularized. Would the result would have changed? And so these were the main, I think, the limitations. Now the endpoints were changed. The trial possibly is not statistically powered. It's definitely an unblinded one. and there are a lot of exclusion criteria. The impact of completeness of revascularization were doubtful, and a longer footnote have definitely given us a better result. I do agree, there are a lot of patients, asymptomatic patients, of course, with significant ischemia, and even symptomatic, mildly, moderately symptomatic. I will give them on OMT, and then only will try. But I will, in a significant symptomatic patient, where the patient is concerned about the quality of life, there are large number of patients who will merit revascularization. I will just echo the big B, Braunwald's big B in cardiologist opinion, just echoing him. The invasive strategy which effectively relieves symptoms of angina is a reasonable approach in a large number of patients for symptom release. Thank you very much for your kind attention.
Thank you, Mohan, for your elaborate critical view of the ischemia trial. But before we draw any conclusions, I think we have to hear Ajit. Now I request Ajit to give his lecture. And Ajit, are you there? Okay.
Yeah, I'm.
Sorry, sir, I have also joined. I was a little late.
Oh, sorry. I can't see you. Where are you?
Yeah, you can see me now.
Oh, yeah. Okay. Right. Okay.
See, can I? Yeah, my talk has been recorded, but then I should confess that since there will be a lot of overlaps in the discussions because we are discussing the very same point. As Mohan said, this is a debate. We are good friends, but we don't agree on a lot of issues. So, can I have the slides on? Good evening, everybody. The topic of today's debate is international study of comparative effectiveness with medical and invasive approaches, the ischemia trial, the invasive versus the conservative approach. Do I have conflict of interest? I'm an ischemia investigator and has an academic bias towards a whole range of issues. So what is the debate about? The debate is about, as PP says, despite the ischemia trial evidence, I would still perform interventions on most of my patients. Obviously, that is not acceptable because he says he does not believe, he believes in the ischemia trial evidence, but he does not accept it. Which is akin to saying that I am monarch of all I survey, my right, there is none to dispute. That is not correct. If I stand by evidence and science, conservative approach is indeed an option and perhaps the standard option. Now, what is the hot scientific question here? We are debating the current status of OMT versus PCI or cabbage in stable ischemic heart disease. The academic question, however, is what is the natural history of stable ischemic heart disease? What are the prognostic markers? Can revascularization modify specifically which has a better outcome? Does it PCI or OMT or cabbage plus OMT or OMT alone? And finally, what is or which is the best option treatment in patients? Now, what do the trials tell us? The PCI versus OMT, the Orbiter Courage Fame 2, revascularization versus OMT, the Barry 2, Freedom trials. Now, as all of you know, there was no difference in mortality in the Courage, Barry 2, and Fame 2 trials. There were obviously design limitations in these previous trials. We were dealing with low-risk patients. There was referral bias by randomizing after coronary angiographic results were known, small sample size, suboptimal revascularization procedures in Courage and Barry 2. And of course, interventional cardiologists did not want to believe the data. So, ischemia was designed. So the design was such that with stable ischemic heart disease patients with moderate or severe ischemia underwent a blinded CT coronary angiogram. CT coronary angiogram was blinded so that the investigators did not know what the anatomy was. It also ensured that there was no left main disease or there was no normal coronaries. They were then randomized to invasive versus conservative arm. And in patients who had a GFR less than 30, they were randomized to invasive and conservative arm without the need for a CT coronary angiogram. Ischemia posed this research question in stable CAD patients with moderate ischemia on a stress test. Is there a benefit of adding to optimal medical therapy, cardiac catheterization, and if feasible, revascularization? That was the primary research question. What were the endpoints? The primary endpoint was a composite of cardiovascular death, MI, or hospitalization for unstable angina, heart failure, or associated cardiac arrest. Secondary outcomes were composite of death from cardiovascular causes or MI and angina-related quality of life scores. The baseline features, as you can see, diabetes was seen in 40%, EF was normal, BP was 130/77, LDL was 83, angina was seen in 90% of patients. Stress imaging was done in 75%, while treadmill testing was done in 25%. The typical patient who comes to your OPD for whom you decide coronary angiogram. What about the coronary anatomy and treadmill testing? In treadmill testing, severe was seen in 55% of patients, moderate in about 33%, thereby taking nearly 85% of these patients with moderate to severe ischemia, and mild was seen in 12%. The coronary anatomy, as you can see, single vessel disease was seen in about 20 to 24%, and double vessel disease in about 30%, and 50% of patients were triple vessel disease, of which 87% had LAD disease, of which 50% had proximal LAD disease. In short, majority of the patients had moderate to severe ischemia and had significant triple vessel disease with proximal LAD involvement. What about the medications? The target of optimal medical therapy included LDL of less than 70, BP of less than 140, non-smoking, and aspirin/dual antiplatelets. Now, the LDL score of less than 70 was achieved in nearly about 60% of patients, and BP was achieved in adequate BP was achieved at about nearly 80%, but there was no smoking, surprisingly 90%. What about the revascularization procedure? The PCA was done in 75% of patients, and CABG was done in about 26% of patients. People seem to have the feeling that the ischemia trial was based upon PCA versus OMT, which is not. It is revascularization versus OMT. About 25 to 28% of patients crossed over to from the conservative arm to the invasive arm over a course of 4 years, which is what is expected. So what were the results? The primary outcome of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or associated cardiac death was not significantly different between the conservative and the invasive arm, despite the fact that the curves diverged at 2 years and continue to diverge. So the story perhaps is not yet over. The major secondary endpoints of cardiovascular death or MI was not different between the conservative arm and the invasive arm. Procedurally, MI was obviously higher in the invasive arm, while the spontaneous MI was higher in the conservative arm. Hospitalization for unstable angina was higher in the conservative arm, while hospitalization for heart failure was high in the invasive arm. The associated cardiac arrest and stroke was not significantly different. What about the recurrent events in ischemia? There was no significant difference in the recurrent events between the two arms. Cardiovascular event rates can be variable. You can have long periods of stability interrupted by episodical disease progression of different phenotypes. So it is important to regard these recurrent events. Was there a heterogeneity of treatment effects? There was no heterogeneity of treatment effects based on the specific features including age, sex, ethnicity, race, geography, ischemia whether it is moderate or severe, anatomy if it is single vessel disease or triple vessel disease, whether there was primary MI, prior PCI or cabbage ejection fraction. In fact, there was no difference whether any of these factors matter. There were obviously technical criticism against ischemia trial. The curves crossover for primary and secondary endpoints at 2 years from randomization and could diverge further, granted. Low event rates and low mortality rates indicative of a low risk group irrespective of any primary features. Spontaneous MI was reduced with the invasive arm. Procedural MI has actually driven the primary endpoint to no significance, but then procedural MI too has its own prognostic implications. FFR was not protocol driven for ischemia confirmation. The completeness of, and it was not randomized to PCI versus cabbage. Completeness of revascularization is an open question, the results of which have not yet been published. What are the limitations of trials? These trial results do not apply to ACS, highly symptomatic patients, LMCA or EF less than 35%. Trial findings are not generalizable to centers with a higher complication rates. Now, which is critical to decide prognosis? Is it ischemia or anatomy? Was any of the ischemia anatomy groups beneficial for invasive treatment? As you can see, the event rates did not differ depending upon the severity of ischemia, both in the invasive and conservative arm. But this CAD severity made a significant difference in terms of the event rates. The difference in 4-year event rates between treatment groups was not statistically significant in any of the ischemia subgroups, be it mild, moderate, or severe ischemia. The difference, however, in the 4-year event rates between treatment groups too was not statistically significant in any of the anatomical subgroups, be it mild, moderate, or severe triple vessel disease. Anatomical severity is prognostic. The ischemic severity is not. The severity of ischemia do not correlate with event rates or mortality. In ischemia trial, the endpoints extend to all grades of severity with no significant difference between the conservative versus invasive groups. However, severity of anatomy correlates with event rates and mortality. The endpoints, however, extend to all grades of severity of anatomy with no significant difference between the conservative versus invasive arms. The health status scores was better off in the invasive arm. And let us look at this particular aspect, that is the completeness of revascularization, which has come as a new controversy in the ischemia trial. What is the relevance of completeness of revascularization in ischemia? This is an important slide. The present results suggest that among selected patients with stable CAD and at least moderate ischemia, cardiovascular death and MI rates with an invasive as compared with a conservative strategy may be improved if anatomic complete revascularization is achieved. Both anatomic and functional complete revascularization were associated with improved freedom from angina and quality of life. These results have not been published, so we need to wait for that. So in conclusion, in stable ischemic heart disease with significant ischemia or triple vessel disease, routine PCI or cabbage versus initial optimum medical therapy has no difference in mortality or cardiovascular events. I will repeat that. There is no difference in mortality or cardiovascular events. Reduction in non-procedural MI, unstable angina, and angina quality of life improves with revascularization. So proceed with OMT, and if patient does not improve, cross over to invasive assessment, not ad hoc decisions on paper. With no malice intent, ischemia results threatens the modus vivendi of the species of interventional cardiologist. Their very existence, their area of expertise, the source of prestige in their very daily bread is threatened. Ultimately, it will not be the WhatsApp gurus that bore your morning, evening hours with their exaggerated concept of self-adulation of their branded sports of heroism, but plaque biology will prevail. And plaque stability and OMT will decide the day. Total atherosclerotic burden as defined by anatomy defines the prognosis and not ischemia, which is also a new issue. Thank you.
Venu, would you like to make a comment?
No, sir, I'll just listen to them because I missed Mohan's talk also.
Debate,
Yeah.
okay. So debate, rebuttal.
I have just a couple of minutes of rebuttal, sir.
2 minutes for
right.
rebuttal.
Ajit was quoting New York Times and Washington Post in the self-adulation of the interventional cardiology. It's not in a scientific journal. Don't you worry about that. Okay, just want to show you a couple of slides. He showed about the ischemia part where we are not very sure about it. This is a subset analysis of the Courage trial which showed that it may not be the number of arteries which is also involved. The ischemia burden also will, look at that, very significant reduction even in the cumulative events. So that is there. These are areas where we are not very sure about it. Let us admit that. I think we should have to admit that. Now, this is again, now I wish we have the pressure wires in the ischemia trial patients used. Unfortunately, it was not done because FAME2 we know. FAME2 has given us an ample proof that if you use physiologic assessment, you could definitely improve the status. And just a mention about Orbita. Have you any idea what happened to the Orbita patients? Orbita was published in 2017 from King's College London. 1 year after, she did not come. Shala was the PI, and she was asked to attend a session in the SKY meeting of 2018, and this was what TCTMD reports. This is not published data, so I hope TCTMD has said it correctly. 85% of the sham control arm in Orbita changed over to PCI. That is some information you should all know. And how good is the OMT practice? Just look at the NCDR data. It is true that we don't have any data about how many patients undergo ad hoc angioplasty in a chronic stable angina. We don't have, unfortunately, data. NCDR says at least 20% or 22% of patients with, even asymptomatic patient with a positive significant ischemia may undergo. And that's what one of the argument is. You lose 100 million for ischemia, but you gain 500 million saving. That is another argument. But then look at how even after the Courage trial, the OMT rate, 43% pre-Courage, 44% post-Courage. What will be the status pre-ischemia and post-ischemia? I wonder. I really wonder. And now it is true that medical treatment has a definite place. No questions asked about that. Every person with a significant symptoms has to be on medical treatment. But there is a large proportion of our patients who will merit invasive treatment. Even from the crossover is lesser in this patient because the power of the study is less. We would have expected a 30% crossover. So I propose again that I am not negating the fact the medical treatment is the foundational treatment. But over and above the foundational treatment, a large number of our patients will merit invasive treatment. Thank you, gentlemen.
Okay. Is there a provision for Ajit to say one or two? Just for a minute.
I probably think because since I was not given the floor, no, basically this is not a rebuttal. See, despite the fact that you have a debate, we have to have this ischemia trial in perspective. And now what is important for everybody to understand is that, see, when a patient comes to you, the classic concept is that you do a treadmill test. And then if the treadmill test is strongly positive, then you send him for an angiogram, and then you decide whatever needs to be done. Now one should understand that in the ischemia trial, this triaging based on treadmill testing or exercise testing is not really relevant. So whether it is mild, moderate or severe ischemia, it does not make a difference in terms of management. That is a very important lesson that we have. Now, what about the number of vessel disease? So you cannot decide to have an intervention purely because the patient has single vessel disease or a triple vessel disease. It has to be based on the total concept. So we need to get away from what our classical concepts have been. Straight away, perhaps we need to modify our thinking on exercise testing. The important question is a shift in paradigm whether we need to do angiogram, if CT or otherwise, in all patients whom you think optimum medical therapy does not really help. So I would suggest patients who come to you, you certainly can do a treadmill testing to evaluate ischemia, then subject him to, if he does not, to optimum medical therapy. If he does not respond, then you cross over. That would be the message.
Thank you. Thank you, Ajit. Thank you, Ajit. I don't know, before we go to our moderators to give the comments, our Krishnan is here. Would you like to say one or two words, Krishnan? You are one of the most important investigators for ischemia trial. So you unmute yourself and we would like to have your comments.
Yeah, before I make some comments about this, I believe that FFR was part of the protocol for revascularization.
Krishna, you are not very clear. I don't know.
He's not clear. The voice is
Not
breaking.
very clear. Your voice is not clear. Something is happening.
You have cut the video. You can cut the video. I think then your voice might become better.
I think you speak to the speaker so that your voice can be more audible, more legible, and more clear.
Yeah, I was thinking, am I audible now?
Yeah, you are better now. Yes.
Okay. Yeah, I was mentioning that actually FFR was part of the protocol and revascularization was governed or guided by FFR itself. That's what I remember. We have done all patients wherever there is suspicious bleeding FFR. It was protocol. That's what I remember. Regarding the ischemia trial, I think most of the points have mentioned. So the problem is that when a patient comes with angina, would you, after the ischemia evaluation, non-invasive, would you really go for angiogram? Now, the problem is that if you don't go for angiogram, then you would be missing at least some cases of LMCA. How do you?
That's exactly the point.
Yeah, that's a problem. So you may have to do another image like a CT angiogram. And CT angiogram is notoriously unreliable. It can rule out the arteritis, that's so good. But even for LMCA disease, if it is normal, it is fine. But the severity of it cannot be assessed reliably angiogram. So many a time when you have moderate to severe ischemia, you are compelled to do angiogram. And once you do angiogram, if you find a light LED lesion, it will be very difficult to come off without doing something. It's a practical doing. In spite of all this clear data, people will, I believe, continue to recommend revascularization in such patients. What do you say, Mohan?
See, I think this is the same question that I was also asking, because even in your Ajit's data, there is 1% of the total population who has left main disease, and it's 1% of the population is a huge number if you take the total number of coronary artery disease patients. So you need either a CT angio, which, as you have already said, that may not be as reliable. So in such a situation, I personally would certainly like to do an angiogram to rule out left main and then proceed whether you are going for a medical treatment or not, depending on the coronary anatomy. This is my own take on the whole approach. But missing a left main is something probably a crime, because you have definite data that left main if you treat, the longevity and the survival is far, far more. And again, the same problem with proximal LAD also. You have to equate left main along with a left LAD, proximal LAD also. These are two areas of anatomical lesions which are extremely important, which we cannot miss. No, your term is over. You can't talk now. I'm sorry, your turn is over.
Moderators, Joni, would you like to give comments?
In every debate, we all enjoy the both sides, the data from both sides. So Ischemia trial is a trial which has contributed a significant amount of data for us. And we also heard the right from the people who has contributed maximum to the trial. This is a new experience for us because most of our major trials are from contributed from outside India or our own world. Anyway, I really enjoyed. And again, I have a question. The LM and critical left main in the non-invasive arm, how much percentage did they cross over to have a PCI?
It is excluded.
Any idea?
It is excluded.
LM excluded.
No, I just wanted to ask you a question. We all know that in chronic coronary syndrome, going by the European Society guidelines, just an angiogram more than 90% is a class 1A indication for a revascularization. No, but whatever, it's a guideline. So again, so if you have a very significant tight circumflex, ostial circumflex, 90%, or for that matter, with class 3 angina or a super dominant RCA with a proximal this thing, will you just leave it? If it were one of your relatives, will you just leave it based on ischemia trial?
No, Jayagopal.
So if you permit me to answer, I can take care of it.
No, now you cannot answer.
Debate is over. It is for us to discuss. Debate is over.
Comments?
Sir, in any treatment schedule, there are two aspects. One is longevity, the other is quality of life. And if your optimum medical treatment does not give you this, you certainly will have to go for angiography and then treat the lesions. There is no question about that. Because both aspects of in any disease, you have two aspects. One is whether you can prolong the life. The second is whether you're improving the quality of life. So the quality of life, certainly, if your medical treatment fails, certainly I would go for an angiogram and try to. But maybe, as Ajit said, a total revascularization may not be possible in all cases. But at least in most of the patients, angina relief is significantly there. Even though the data did not substantiate my claim, I would certainly think that angina relief will certainly be there.
The studies
the patient's life. No, it is not the quality of the cardiologist's life.
The studies have shown that patients with chronic stable angina, almost 80 to 90% of the patients can actually get a good relief and good quality of life by medical management. So we are mostly discussing about 10 to 20% who may not improve at all or may have still a poor quality of life, and what is to be done. The second point is about the left main. Of course, in ischemia trial, they have given the cardiac CTA for assessing left main, and Krishnan is of the view that there is a possibility that some of these patients may be missed out. So that is a very important point which Venu has rightly brought out. I would feel that patients with very significant positive TMT, where less than 6 minutes they become positive, I think leaving them to medical management without knowing the anatomy may not be a wise decision. At least based on our own experience, as well as the way we look at the coronary anatomy. Because some of these patients can have left main lesion. In a large number of trials, it has been shown that patients with chronic stable angina, 7 to 10% can have a left main disease. I think we should not miss it. So, before I conclude my discussion, I would ask Sajeev to give his comments, and then we can conclude the session.
Ischemia trials showed that all-cause mortality is low in stable coronary artery. That is one which we have to remember. And it also showed that it is not necessary to rush to the cath lab when there is some ischemia demonstrated on a stress test. And anatomical findings may be precede over the physiological findings like a positive stress test. And the thing is that, and also in patients with CKD and chronic stable angina, the mortality is much higher, but the intervention did not prevent this mortality. And another thing was revascularization may not prolong life, but prevent spontaneous MI, alleviate symptoms, and improve quality of life. And for your information, I think we are going to the Ischemia extent trial, which will be following up these patients, and we can see whether these curves will diverge further or not. They are following up this.
Good. So the winner of the debate, sir?
And before that, I will also share my own experience also. I have started practice at a time when the coronary angiogram and intervention and bypass was not that popular. Even now, I have got patients who had this myocardial infarction. They had some degree of post-infarction angina, and on medical management, they settled down, and they are still leading a normal life from the year of 1984-85. So there are still patients with chronic stable angina who may continue to do very well with optimum medical management. But those who are still having symptoms and those who are having poor quality of life are candidates for coronary angiogram and revascularization if it is required. I think there is no winner at all. I thought that there was no debate. I think two people were giving their data in a two different direction, and I think they have given us the data, and all of us can take from this discussion whatever is correct for our patients, and I think both are winners.
Thank you, sir. So I think I take this opportunity to thank all the chairpersons, the senior faculty, moderators, and excellent debate on this. And with this, I think we come to the end of day one on the scientific session, and I hand over the mic to our secretary, Dr. Nandakumar, for conducting the proceedings. Dr. Nandakumar? We'll have a bash.
Small is allowed only up to the... We can sit on the top? Some chairs? We can put our chairs. We can do small medium so that can have a small. Small, only have this small.
Why is the session over?
Medium.
If you want to sit, carry your chair.
That's all. So welcome all the members, both those logged in. Moses, have people logged in the general body?
No, not at they're just logging.
Then we'll wait for about some time.
You will be seeing it here.
I